Good morning. Just give us few minutes. We'll start in the next few minutes. Thank you.
Yaushe ne ai na baka? Aka ce wani idan na waje na.
Morning, sir.
A'a, yana da wajen ka, ai ban washe shi. To, akwai wani kiɗin da ina da ba na wasan ɗin bane. Ko? Wannan shi ne. Ah, bello. Quindi no, è tutto dopo. Poi
Hello, good morning, everyone. Thank you so much for joining us today. Very happy that by 10, even before 10, we had the 100 on Zoom already, and I believe others are joining through the link through YouTube. Thanks a lot. Very happy many people have registered. There are over 600 people that have registered for the training. And I'm even excited because this is one of the trainings that, to me, is a foundation for our moving forward with the transition from Bachelor of Physiotherapy to Doctor of Physiotherapy. Of course, we have always said it's not about the title. So today we are going to discuss what does it really mean to practice first contact or direct access practice. So thank you so much for joining, everyone. Let me just confirm that you can hear me very well so that we'll then proceed.
Good morning, sir. We can hear you well.
Okay, wonderful. Okay, so I can see messages from the chat forum that people can join. Of course, people can join through this Zoom group. It's 100, but we have a link which automatically redirects you to our YouTube channel. And we didn't bother to upgrade the Zoom because the YouTube is unlimited, and also people can be able to pause it and continue, and we can be able to have the link from the YouTube to be able to release to people to listen to it again, or those that have not joined to be able to listen to it. So I'm confirm that people can join the YouTube and then we'll start. So just give me 2-3 minutes. Let me confirm that people are able to join the YouTube and then we'll start. All right, so we are going to continue. Thank you so much. Just wanted to confirm that everyone can join. Someone just asked how you can get the link for the YouTube. If you join the Zoom, it's going to show you that it has reached the maximum capacity, and then you will see where it will say watch live stream. So just click that link that says watch live stream, and you will be able to join the YouTube channel. And please, for those that are joining through the YouTube channel, you may not be able to raise your hand and ask questions or make comments. We guide you on how to send your questions or comments so that it can be sent to us. We'll read it out so that it will be, everyone will be carried along. So as I've said, I'm very happy, I'm excited. Thank you so much. I want to specifically thank the coordinators, central coordinators, Ile and her team, Dara, Eleke, Idris, Minu, Bashir Sabo, and all the others that have been at the back end coordinating centrally. I also want to thank all the state facilitators and coordinators. It's a statewide workshop, it's a national training. This, I think, is the first time that we are having a training that everyone can have the training in their state without the need for travel and the problems with travels, accommodations, and what have you. And now that we see that it's working, even though we have not done the hands-on, but at least I can see the commitment from the state. And by the time we have the hands-on, if it works, then going all our hands-on training, we won't allow people to travel. We are going to have coordinators, facilitators, one person from each state or two people from each state that will come to Abuja, and then we'll train the trainers. And then after that, they will go back to their states and they will step it down. That's exactly what we did with this training. We had almost 30 people coming to Abuja. We accommodated them in the board, and we had the training in the board office and also the hands-on at the National Hospital in Abuja. And it was a 2-day train the trainers. All of them are experienced clinicians, and therefore it wasn't a workshop where someone facilitated and taught them things. All we did was to just sit down and agree on a particular format for assessment, evaluation, and diagnosis in physiotherapy. And when we agreed on the template, they now went back to their state, mobilized, and that's what they are going to serve as the facilitators for each of those states. I know there are states that have over 100 participants that have registered. For example, Lagos. I know also places like Abuja and Cross Rivers that have more than 50. And we don't want one facilitator to train 100 or 50 or 70. And those that participated in the train the trainers can then select 2 or 3. For every 15 participants, we should have at least one facilitator, and they will now do another train the trainers within their state. And then after that, we'll have enough number of facilitators that are going to help with the hands-on when we fix the date. We want to apologize for the fact that we have not been able to, we are not able to do it tomorrow, or will not be able to do it tomorrow, the hands-on, because of the strike. Many states complained about the issue of getting patients, and also the issue of having the venue secured because of strike. And we have shifted it until we see what happens with the strike. If the strike will be prolonged, then we'll think of alternatives. Maybe states can think of how they can have private patients that can come in and also get an alternative venue. The workshop is not really about techniques of assessment, so teaching you the actual techniques of assessment, but the workshop is about the process. I'm going to explain this. It's going to be more about the process than the actual techniques. In subsequent trainings, we are going to focus more on the techniques within each of the different specialties, but this workshop is going to focus on about 4 things that I'm going to mention, and therefore their gadgets, it will still be in order because we can still be able to navigate and have the workshop. So in case the strike is prolonged, we'll think of an alternative so that it will not take very long before we do the hands-on. But for now, we are going to watch and see what happens with the strike. For those also that are not able to join this particular virtual session, of course, it's going to be released, the link, either to the YouTube or to the Zoom link recording will be released. But we can also have another one. We wouldn't mind having another session of virtual before the hands-on. And people can join who have not joined, or those that have joined, maybe network has not allowed them to be able to listen very well. And it will give opportunity for interactions, which a video that you just listen to or watch may not provide that. And so I'm also going to say that we are going to focus a lot on the interactions. Please let it not just be a lecture that we continue to just listen to and without participation. Let it be an active thing where all of us, we discuss experiences and the new the same for many. Will not be what is available or applicable in many of our hospitals and many of our clinics across the country. So this is just by way of background information. Thank you once again to all those facilitators, coordinators, our own team, central team, and you, the participants. May God bless you all. Are we each required to bring a patient during the hands-on practical session? I never even thought of this, but this is wonderful. It's wonderful. That's even one way to solve the problems of not having patients because of the strike. So if we feel, I think since we have a WhatsApp group for each state can discuss how do we go around this strike problem. If people come with their patients, and as the more the patients, the better the learning, because the focus will be on evaluation. And the best way to learn evaluation is if you repeat it on different patients, because you are going to see different data, and therefore you are going to interpret different data. And that the more the patients, the better the learning. And if we can be able to get enough patients, because everyone has a patient that they can bring in, then we can solve the problem. As I've said, if you get a hall and you can be able to get 2 or 3 couches to be moved there, or maybe a private clinic, someone volunteers to have their private clinic as a venue, then we can be able to go ahead. So please let states discuss this on their platforms, agree. We don't have to have the hands-on the same dates across the states. This is something that's why we are decentralizing. So that every state will look at their peculiarities. How will they do the training? Where will they have it? Their feeding, can they coordinate and bring in a vendor with them, or will they bring food from their homes? That's why we decentralize, so that people can choose what will be more convenient for them across the states. Yes, so that's it. So maybe we can discuss this later when we come to the interactions. I'm going to start with the presentation. So assessment, evaluation, and diagnosis of physiotherapy conditions. As I've said earlier, the focus of this workshop is not about the technique of how you assess patients using, for example, outcome measure. How do I use back balance scale? How do I use assessments for SIG test? So the focus is not about learning how to apply or how to do those techniques or interventions. In fact, the whole thing, you can see there is no intervention at all. We are focusing more on the process from the time you begin to have contact with the patient until you make a diagnosis. So the whole of this is not going to go into treatment or interventions. There's also prognosis, which is not part of this, is going to be part of other workshops that will come in later. So the focus, as I've said, it will not be on the techniques. We will learn techniques because there is no way you will assess patients and you will not learn something new, especially from the resource persons that have had experience. You mentioned a number of assessments and things like that. But the focus of this will be from 4 perspectives. Number 1, I've mentioned the issue of upgrade or transition from bachelor, where mostly we get referrals, to doctor, where holistically we can have patients come to us directly. So this process, how does it differ when you have a bachelor and when you have a doctor of physiotherapy, a professional, or a first contact profession? So we are going to look at the process. The American Physical Therapy Association, in America, everyone practices as a doctor of physiotherapy. And that is one of the reasons possibly why I know from the board we hardly see JAPA to the US. Because in the US, you must have a DPT to practice there. And since many of the people that are traveling out of the country don't have a DPT, they mostly go to other countries that accept a bachelor. So in the United States, since by law, everyone must have a DPT to practice, their template is one that recognizes the professional as one that can be able to identify underlying diseases, apart from the ones that are within the scope of your practice, so that if you identify them, you can refer. Because it's unethical that you see a patient who has another disease that is not within your scope of practice, and you continue to focus on what is within your scope of practice, and you ignore the other underlying diseases. At some point, it will continue to get worse until the problem now is seen by the patient, and they go to the professional that's supposed to see that particular underlying disease, and a harm may have been done. And so the assessment is different from what we have at the moment. I was very happy when we met in Abuja, almost 30 people that were in that hall that we met. Initially, what we did was to say, okay, how do we do our assessments? Everyone mentioned. We then presented the APTA template. And at the end, we agreed that if we are going to practice first contact, that we should adopt the APTA template. I'm going to show you the template later and also explain the difference between what we do now and what the doctor of physiotherapy professionals do. So that is one of the things that are very, very important in this workshop. That transition, the process now changing because of the transition. That's number one. Number two, very importantly, evaluation. And I know our practice. I know we do a lot of assessments. I know sometimes some of us depend on the referral diagnosis to now set our treatment in motion. But evaluation, which is done using clinical reasoning, the evaluation is about interpreting or making sense of the data that we have collected. Now, why is this very important now to us? Because of this transition to DPT or to first contact, that patients can come to us directly, and therefore there is no diagnosis. We are the ones that will know about the patient's condition. We will collect the data, and therefore, if we want to get a diagnosis, a meaningful problem that the patient has that can be treated, then we must be able to interpret the result of the assessments that we have done. Yes, slide is static. I'm just giving you background information. We'll go into the slides. Bear with me, because this is something that is a new concept, at least for me, and I believe for some of us here also. But I just want to explain what the focus of the workshop is all about. So I've mentioned the transition to the first contact will require different process of assessment. That's number one. Number two, issue of evaluation, that we need to be able to assess the patients and interpret the assessment, make sense of what we have assessed to be able to make a diagnosis. This workshop will also focus on this issue of evaluation. Then number three, systems review. Systems review. Remember, I mentioned earlier that if patients will come to Raw's first contact, just like a patient will go to the GOP, they have low back pain that is mechanical in nature, it's movement related. The medical doctor has no responsibility eliminating the source of the pain. All they do is to give pain relievers, and that does not eliminate the pain. But they are the ones that will assess the patient. They will say, oh, look, the condition that brought you is not even my own scope of practice. but I'm going to just give you a drug to relieve the pain. I'm going to refer you to a physiotherapist. Or the patient may come, they have speech therapy problem. I say, oh, no, this is go to speech therapist. The patient may come cardiology case, go to the cardiologist. The patient urologist that needs to see refer. Now, that physician in the GOPD is able to identify problems that are within their scope of practice, but also identify problems that are not within their scope of practice. What is within their scope of practice? They will make a diagnosis, they will treat. What is not within their scope of practice? They don't have to make a diagnosis. All they need to do is to build a case that there is a red flag. This is a case that I suspect strongly that another condition exists that is not within the scope of my practice, and therefore I need to refer. And then he goes ahead and refer. So this is what we want the physiotherapist to be able to do as a first contact professional. We want you to be able to not just assess patients for physical diagnosis, but assess patients to see if there is possibility of an organic pathology that a physician needs to see. And then you now refer to the physician. Or if there is any case of heart disease that is organic in nature, send to the cardiologist. If your center has that system of not just sending to physician, but sending to specialist. But at least if your center insists, and there is no legislation or any regulation to back you up to send to specialist, at least send to the physician who will then send to the specialist. So the issue of systems review is what helps you to be able to do medical screening, not for the purpose of establishing a diagnosis, but for the purpose of identifying red flags so that you refer to the specialist that you're supposed to refer to. This is number 3, focus of this workshop. Number 4 is physical diagnosis. Many of us make medical diagnosis. We complete our diagnosis and we say our assessment of plaquing and we say cerebral palsy. We say hemiplegia secondary to stroke. We say lumbar disc prolapse, lumbar spondylosis. All these are medical diagnoses. They are not physiotherapy diagnoses. They are not physical diagnoses. So one of the focus of today's workshop is to identify what is physical diagnosis and how do we make physical diagnosis after assessing the patients and evaluating the results of the assessment. How do we make a physical diagnosis? So remember 4 things. Number 1, the process, the change in process towards first contact. Number 2, evaluation. How do we interpret results of assessments using our clinical reasoning? Number 3, systems review, to be able to do a holistic approach to assessment that does not only identify what is within the scope of our practice, but that also allow us to see red flags that will refer to a relevant clinician. And then finally, physical diagnosis. What does it mean and how do we make physical diagnosis? And this is what I would want the hands-on to also focus on. As I've said earlier, it's not primarily about learning new techniques, but it is about having this 4 mastered so that our practice will change according to the transition to first contact. So thank you so much. For those that want us to go to the slides, I'm going to the slides now. Yes. So physiotherapy, let's look at the physiotherapy body of knowledge and its scope of practice. Of course, as we discuss the body of knowledge, we also will look at the identity of the physiotherapist. There are slides because they are old. Pictures. Because they are old ones, I did not include them. But if you have watched a movie where someone lost their memory, and there are many out there. That if someone had lost their memory and they don't know who they are, they begin to get confused, they get agitated, and they do all sorts of weird things in the society just because that identity means a lot to them. And there's something that's happened to physiotherapy a long time ago when Even now, I believe many people are having trouble with the identity. So one of the things that we do is to define ourselves based on the treatment that we give. When I completed my PhD and came back home, many stations kept calling me for interviews, and they asked me what physiotherapy was. 2012, that was 2012, 2013. And I will tell them physiotherapy, the profession that treats conditions using physical means, and then I will start to list the physical means. It wasn't until I did the DPT in 2013 to 2015, between 2013 to 2015, that I got to know that I was defining it completely wrong. And I had a first degree, a master's, and a PhD. I lost my identity, didn't even know what physiotherapy really was from the identity perspective. And that changed the way I see physiotherapy. It's completely changed it. So we are going to look at the definitions, but defining ourselves based on the treatment that we give, it narrows our approach, it narrows the way people see us. Because what is most important for a professional is not the treatment that they give. I keep giving an example. I don't like all these comparisons, but it's a good example that I thought people will see outside our own profession. A medical doctor is going to prescribe a drug, but that drug, who developed it, is a pharmacologist. It's not the medical doctor that developed it. And by the time he makes his prescription and it goes to the pharmacy, and the pharmacist looks at two drugs and say, oh, no. From my knowledge, and he has the knowledge of drugs more than the medical doctor, and you'll be able to say that, look, these two drugs, they have interaction effects. If you take it, you are going to have another disease that is even worse than the one that the prescription was meant for. Therefore, you will now say, we are not going to administer these drugs. We will not dispense these drugs. Go back to your physician and ask them to change the prescription. And another thing is, you go around town, especially in villages or in markets, you'll see people that have never gone to school carrying a basket with drugs. If you say, I have headache, they will give you Panadol. If you say you have, just tell them the symptoms, and they are going to give you a prescription. And they are very good because they do it often. Day in, day out, they do it, and therefore they are getting better. They know what drug to give them. And therefore, what makes the doctor special? When what he prescribes, the treatment is not his. Someone developed it. And if he prescribes, a pharmacist can return it and say that you don't even know your job. How can you put these two together? They can't work. And that what he does, someone out there is doing something similar, maybe not at the same level. But what distinguishes the doctor is the fact that he can use his clinical reasoning and he can do differential diagnosis, something that all those that are involved in the issue of the treatment cannot be able to do. You'll be able to say that, look, because of these symptoms that you have, the combination gives this type of diagnostic criteria, and therefore it is this condition, not that. And that because of this condition that you have and another underlying condition that you have, your treatment will look different from another person that does not have that underlying disease. That clinical reasoning, that thought, and that ability to be able to navigate through different scenarios and conditions and case studies is what makes the doctor to be a formidable person. And therefore, as a physiotherapist, if you focus on the understanding of treatment, then you have veered away from your identity. You're supposed to have that clinical reasoning to be at the core of your practice. That is what makes you a professional. And we are going to see the definition that brings together all those aspects that are important apart from treatment. It ignores the assessment and clinical reasoning skills that help with accurate diagnosis and patient management. Patient management, not patient treatment. Please, can I plead with all of us to please mute ourselves? Please, let's all mute ourselves. So there's a difference between patient treatment and patient management. Now, I would have asked questions, or maybe let me just ask, maybe even if it is just one person that we take, as I've said, I would want it to be interactive. What's the difference between treatment and management? One person, anyone just volunteer? Can raise your virtual hand. And it will be good if we fast with this, because that will help us to do a lot of interactions and go through the whole sessions in good time. Anyone? There are 100 people on the Zoom, and I don't know how many on the aha, good. Rita, go ahead.
Okay, sir. Good morning, everybody. So when we're talking about treatment is one component of patient management, whereas management is more encompassing. It includes both the assessment, the evaluation, the treatment, the prognosis, diagnosis, and the outcome. So it's broader. It's a big umbrella per se, whereas treatment is just one of the components of patient management.
Exactly. Thank you so much, Rita. That's wonderful. That's exactly what it is. So if we focus on treatment, we are only focusing on one component of patient management. Okay. Yes. So you are only picking one out of 6, because by the time the patient comes to you, you don't just give treatment. I mean, you accept the patient, it's like going to a chemist and you just say, I have headache. And then they will just bring out a drug and give it to you. But what if that headache is from cancer? What if that headache is from an inflammatory condition within the brain, or any other source? So without assessing the patient, you just give them treatment. That treatment does not eliminate the source. So you assess the patient, you must have a diagnosis, because you can have 2 or 3 symptoms across different conditions. And then you now have a prognosis. From the condition, when do I expect to discharge this patient? When do I expect the patient to get better? Looking at some factors, specific factors. And then you now begin to give the intervention. And after the whole of that, because in rehabilitation, you are expecting the patient to go back to the community. When they go back there, can they continue with the activities of daily living? And that is looking at the outcome of the treatment or the assessments or everything that you have done in the clinic. So these are the 6 components of patient management. Treatment is just one, while management encompasses all. And therefore, if you only define yourself according to the treatment given, it ignores the assessment and the clinical reasoning, which is the evaluation that help to have an accurate diagnosis and also to have management, not just treatment. It can also mislead the public and other health professionals. And this is exactly what's happening. This is exactly what's happening. Wherever you go to, I mean, we had a training, World Physio Day. When I returned from my PhD, they invited me 2012, I think, in Kano to present a paper. And when I presented things that were out of the passive movement that we do and the massage, when we finished, the chairman of the occasion, who is now an executive secretary, at that time, I think was a senior lecturer, now a professor and an executive secretary, the chairman of the occasion, when he finished, he said, is this physiotherapy? You didn't present on physiotherapy. I didn't hear you, and he was moving his elbow up and down. I didn't see you talk about, the passive movement, the massage, and all that. So because we were talking about assessment, we were talking of, what I presented on was even clinical practice guidelines. And in the clinical practice guidelines, we're talking about all these issues of the components of patient management and how physiotherapists can do assessment, evaluation, and all that before they begin to think of treatment. But because what we have presented to the public has been about the treatment that we give, the physical means of treatment, and all that, the infrared, the what have you, the exercise. That's what they want to hear. So that's what they see. It misleads them about our training, our knowledge, and our capabilities as physiotherapists, and that needs to change. So as I mentioned after, and when you see physical therapy, is because I picked the information as a quote And therefore, I did not change it to physiotherapy. And I mentioned why I chose APTA, because APTA currently is practicing DPT 100% all across the states of the United States. And they were the ones that developed this according to the first contact practice. So what they did in 2013 was to adopt the vision of transforming society by optimizing movement to improve the human experience. It was from this that they began to look at the identity of the physiotherapist as human movement system, that we are movement specialists. Either there is a problem that the source is movement related, or that the source is not movement related, but the treatment to be given will be movement related. So whatever happens, even if you give an intervention that is just to relieve pain, you are given that intervention to relieve pain so that to empower the person to move. That will be it. Whatever you do, the identity is about movement. And you have to relate it to movement generally because that's the identity. And therefore, they say the physical therapy profession will define and promote the movement system. So the movement system as the foundation for optimizing movement to improve the health of society. So recognition and validation of the movement system is essential to understanding the structure, function, and potential of the human body. So that's the issue. What's our identity? The human movement system. That is our identity. We'll talk about the body of knowledge and then begin to see the scope of practice. So now what's the definition? Who are we as physiotherapists or physical therapists? Now, look at the key words in this definition. Very important. Look at the keywords. If we are able to gather all this, and at the end of the day, we do all that based on those keywords that we have, then our practice would have been upgraded and will be seen from different light. So the physical therapist will be responsible for evaluating. Can you see evaluation comes first? That's why I said number 2 in the 4 things I will focus on in this workshop will be evaluation. Responsible for evaluating, because that's the most important thing that makes you a professional. Evaluation, interpreting the results of the assessments that you have done, using your clinical reasoning to make sense of it and say, this is the problem. So evaluating and managing. Remember when Rita was given the difference between treatment and management, she said evaluation is one of the components of management, patient management. You have assessment, evaluation, diagnosis, prognosis, intervention, and then outcome. But why is it that they still remove? They would have said responsible for managing an individual. But because they want to bring out that evaluation to show you that it is what makes you a professional, it was brought out, even though it's still there in managing, but it's brought out to show its importance. So responsible for evaluating. So that's the first thing that the physiotherapist is known for: evaluation, interpretation, clinical reasoning. If that is not there in the practice, oh, you are not a physiotherapist. I don't want to mention the name because people will begin to fight with me. So I will not mention the name, but you can find your identity, but you are not a professional physiotherapist. So you do evaluation and you consider other components of patient management like prognosis, the hospital, to see what happens to them in the community. This is what makes you a professional. So, but what do you evaluate? What do you manage? Movement system. If you are treating stroke, you are not a physiotherapist. If you are treating cerebral palsy, so all those, my CP friends, pediatric friends, if I ask you, what are you treating? And you say, I'm treating cerebral palsy. No, you are not. That's not physiotherapy, because that's an organic pathology. So it's the movement impairment or the movement system that you are evaluating, that you are managing. When we get to physical diagnosis, you'll see why I say you are not treating stroke or cerebral palsy. Because in our diagnosis, we don't even say secondary to stroke or secondary to cerebral palsy or secondary to lumbar spondylosis or lumbar disc prolapse. And we'll discuss that
ahead. Let me just be looking at time so that I will not be talking too much and miss out on the most important things. So now another thing is that we evaluate and manage the movement system across the lifespan. That's why we have pediatrics, we have geriatrics, and we have those that are in between these two. And why do we do this? To promote optimal development. So in a child, you want to promote optimal development. How do you promote optimal development? By evaluating and managing the movement system of the child so that you promote optimal development. You diagnose impairments. So you want to diagnose impairments, activity limitations, and participation restrictions. If, as a physiotherapist, you are only focusing on impairment, then your practice is limited. You evaluate and you manage at the level of impairment, at the level of activity, at the level of participation. So the first thing, can you see we are not even talking about intervention? We are talking about making a diagnosis in impairment, activity, and participation restrictions. It is after you have done these very important components of patient management that the definition now brings in intervention or the treatment. Then provide interventions. But even provision of the interventions must be targeted towards something that makes us professionals and at primary healthcare level. Can you see primary healthcare coming in the definition? Provide interventions targeted at preventing, so prevention. Who says we can't be in primary healthcare? Because we don't, the definition of primary healthcare does not apply to us. We do prevention. We do assessment. We do diagnosis. We do prognosis. We give intervention. But we even go ahead and give rehabilitation. So preventing or ameliorating activity limitations and participation restrictions. So for me, that's why I brought this definition, because it seems for me to be the most holistic definition of a physiotherapist or definition of physiotherapy. So look at the keywords. In this workshop, our focus will be on those keywords. How do we become this physiotherapist that has not been defined in this definition? So the movement system is the core of physical therapist practice, education, and research. This is what they said. That's why I left the physical therapist there. Movement system is the core. You don't understand the movement system, forget it. And that is why we have this training. We did it this year. I think there were only about 10 people. And next year, we are going to do it again. Functional anatomy for functional training. Functional anatomy for functional training. In school, we learned about muscles, origin, insertion. But what we're looking at now for us to understand movement system is that if I'm going to pick a cup and drink, what muscles combine do the task? So that if a person has an injury or a disease and they cannot drink, I'm going to now be focusing on those muscles, not the muscles that are not involved in the activity. Because I'm going to ask the patient, what activities are important to you? If he says the activities, the moment he says the activity, I'm already looking at the muscles that are involved in the activity. And they are the muscles that I will focus on when it comes to assessment, when it comes to treatment. Is it weakness? Is it restriction in the joint? Or is it coordination problem? How do I make those muscles work together to bring about that movement? This is who we are. This is what we do. If you don't understand anatomy, how then can you be able to understand movement system? And how can you be able to treat it when you don't even understand it? And therefore, our trainings now will focus a lot on functional anatomy for functional training and the issue of the human movement system generally. What is it? What other systems work together to bring about movement? And we are going to look at some of those things even in this training. So as independent practitioners, doctors of physics, please don't mind this box outside my window. I hope maybe some of you can hear it, but some may hear it. As independent practitioners, doctors of physiotherapy in clinical practice will embrace best practice standards in examination, diagnosis/classification. So this is another thing. We'll discuss the issue of the movement classification system. How do we diagnose as physiotherapists? what forms the basis of our physical diagnosis. We are going to look at that in this presentation. We give intervention and outcome measurement. And we all know physiotherapy is the only care profession that evaluates movement at the whole body level and does that to either prevent or treat diseases and injuries. Only physiotherapy. So physiotherapists usually focus on special tests. Now, this is a problem for our practice. We usually focus on special tests and impairments rather than movement. And I'm going to show you some softwares that are used to assess movement. So when patients come, we do our VAS, we do our range of motion, we do our back balance scale, we do our SIJ test. They are impairment, they are looking at impairment. Someone that has a problem in their hip, and because of that, they shift towards one side. They are going to put weight more on that side that they shift. That is the side away or the opposite of the side that is painful in their hip. Now they begin to have pain in their knee. And you now want to treat the knee. You will continue to treat the knee because the source of the problem is not the knee. It's because of a sustained alignment that the knee is having symptoms. If you now begin to test about pain at the knee, and you do all your tests at the knee, at the end you treat the knee, you have not solved the problem of the patient. And therefore, looking at or assessing the movement itself generally, the movement of the body, the alignment of the body, is going to help you to be able to get to the source. And I gave an example earlier that a medical doctor is known for his ability to get to the source. Because someone that goes to chemist and say, I have headache, they give him Panadol. A patient recently went to the hospital. They had a thrombus in the veins, in the thigh. And when they went, they saw it, they gave them pain relievers and anti-inflammatory drugs. Even after a test was done, an ultrasound was done, and the diagnosis was there, they went to a chemist and they got, well, I said, what are you talking about? You get painkillers, and when they said there is a thrombus, can you go and see a specialist? They went, they saw the specialist. The specialist said, wow, you are lucky. She would have died. She would have died. And they now gave them a drug that targeted the thrombus and then took care of it. So very important to get to the root. And for physiotherapists, we're not going to look at organic pathology and solve a problem. We are looking at movement impairment. So how can you solve a movement-related problem if you don't assess the movement itself? And as I've said, I'm going to show you how to do these assessments of the sustained alignment of the body and also movement, functional movement of the body. These are very important issues to deal with. So this example that I give, patient may report with patellofemoral pain and the assessment and treatment directed towards the knee, when in reality, the problem may be from the hip. So if you look at sustained alignment, you would have seen that at the hip, there is a misalignment. And therefore we say, okay, that's where the source of the problem is. Let me go and get the alignment. When you get it, you say, oh, there is pain on that side. Okay, let me treat the pain on that side because that's where the source. Forget the knee, treat the hip, and the knee will take care of itself. In a patient with high risk of fall, emphasis could be placed on postural training. So you keep postural training, you are a neurologist, neurophysiotherapist, postural training, but the patient may have a musculoskeletal mobility problem with the spine, and that is why they are falling. And therefore, it is a musculoskeletal physiotherapist that needs to see the patient. Why? You need to look at alignment, you need to look at movement. So emphasis should be on movement analysis, and that is why in the board, from next year, any department that does not have a movement lab where you will do movement analysis, they will not get accreditation. You can lack anything and you can get a, what is it called? A partial accreditation. But if you don't have a movement room or movement lab, because I don't want to say lab, people will begin to think of research. Whatever we'll call it, there must be a place where you will assess sustained alignment and movement of the patient so that you will target the source, not just the symptoms. So emphasis should be on movement analysis during assessment and targeting interventions at the appropriate movement dysfunction. Focus on integrating all systems that interact to produce movement. And we are going to see these as systems. So first contact, the physiotherapist is equal to the physicians. We all know this. But what does it mean? It is not about comparison, but what does it mean? The physician identifies musculoskeletal problems based on pathoanatomy. Now, this is where the body of knowledge comes. Pathoanatomy. When we talk of organic pathology, what we are talking about is when you have an infection in a muscle or in a joint, when you have a tear, when you have a breakage, when you have inflammation. All these things are targeted towards a particular anatomy of the body. So there is pathology in the anatomy. You are treating the pathology in the anatomy. That is what physicians do. And therefore, they do their assessment, they do their evaluation, they are going to rule in an organic pathology. And what they do at the end, they treat the symptoms and consequences using drugs and surgery. But as a physiotherapist, I identify neuromusculoskeletal problems based on what is my body of knowledge, pathokinesiology or kinesiopathology. I'm not looking at the muscle and the fibers, whether they have disrupted, they have torn, there is a breakage in the bone, whether there is an inflammation inside the muscle or the joint or the brain, or whether there is an infection there. No, that's not what I'm treating. What I'm treating is movement that leads to pathology, or that there is pathology that leads to movement impairment. So pathokinesiology is when you have an organic pathology leading into movement disorder. For example, you have Port's disease. There is an infection in the back. But as a result of that, the limbs become weak. When you have stroke, it's an organic pathology. That is what sets in first. But as a result of that, you have hemiplegia, you have movement impairment in the limbs or in the face or wherever. This is pathokinesiology model. But kinesiopathology is when you bend to pick an object and you feel pain in your back. When you sit for a prolonged period and you have pain in your back or neck. When you use computers, this is kinesiopathology. The movement-related disorder comes first. As a result of that prolonged sitting, or as a result of picking the object, an organic pathology sets in. So you begin to have inflammation, you begin to have some kinesiopathology starts from the movement disorder or the movement impairment. And therefore, in pathokinesiology, physician or medical doctor sees the patient and refer to the physiotherapist. Kinesiopathology, the physiotherapist sees the patient and refers to the medical doctor or the physician or whoever it is within the realm of work. So this is the body of knowledge. My body of knowledge, pathokinesiology, kinesiopathology. Now, what do we do after assessing, diagnosing, according to this kinesiology body of knowledge? We treat the cause. Now, go back to what I talked about movement analysis. You are not treating the symptom. Treating the symptom is just by the way. It's just like someone that needs surgery that they give a pain reliever. It doesn't stop the surgery from being done. So whatever symptom you treat, your surgery is to eliminate the movement-related problem that the patient has. So treat the cause using movement. If you don't assess the movement, you are not going to remove the cause. This is very, very important. This is very, very essential. Now, what is the human movement system? There are systems. These are systems because musculoskeletal system is a system. Neurological system is a system. Cardiovascular, pulmonary, endocrine. These are all systems on their own. But they come together to bring about movement. And that is why human movement system is called system of systems. So it's a system that brings about systems. Now, how do they come together? How do they work together? The musculoskeletal system is the effector. So that's what we see. And that is why we are starting with it. When you pick an object, it is because your muscles contract to move your bone at a joint or across joints. So that is how movement comes about. But do the muscles just decide to move? No, the nervous system is the one that regulates the movement. It is the nervous system that says this movement should come, and it sends signals from the brain down to the muscles, and then they contract, and then the movement takes place. And therefore, the nervous system is also part of the human movement system. If you don't have blood that takes oxygen to the muscles or to the brain, the movement will not occur. And that is why sometimes people will have fatigue, or they will even faint while they are doing activities of daily living. And therefore, the cardiovascular system is part of the human movement system. If you don't have oxygen coming into the system, even the blood cannot take anything. And therefore, pulmonary system is part of it. All the chemical reactions that happen when the blood picks the oxygen and it takes it to where it will be used, and then it will be used, it needs all those substances that come from the endocrine system. And therefore, the endocrine system is also part of the human movement system. But because all these organs are enclosed by the integumentary system, and therefore the integumentary system is also part of the human movement system, even though I've not included it here. And when we did DPT, integumentary system, oh, fantastic. It's part of some of the workshops that we're going to do next year, the integumentary system. A lot has changed since we finished school. They have so many different techniques, apart from just the ultraviolet rays that we learned from in school. Physiotherapists now can understand a lot about wound management and other things that have to do with skin care. And this is also part of the human movement system. So these are the systems coming together. And that's why we have musculoskeletal physiotherapy, neurological physiotherapy, cardiovascular, pulmonary, and what have you, because they are part of the human movement system. And even though there could be an organic pathology in them, but there's also movement-related issues with them. And therefore, we come in from the human movement perspective, not the organic pathology perspective. Now, there are inducers of change in this system. Sustained alignment, I've mentioned this. If you sit for a prolonged period without ergonomics, you are going to end up having pathology setting in your back or in your neck. And therefore, these are important things for us to look at under human movement system. Repetitive movement. If you do an activity over and over and over, you may have movement-related disorders. Then there are modifiers of the changes. So those inducers, they are affected by some modifiers, which are intrinsic and extrinsic. The intrinsic, individual characteristics. Someone that is obese may not be able to have the opportunity to, since you see someone sitting and say, look, so bring me this. Please, can you help me with this? Can you do this for me? Can you do that? The sustained alignment will affect them possibly more than someone that can just quickly stand up, pick the object, come back, do other activities, and then interrupt sitting with standing and other activities. So these are intrinsic. And therefore, in our assessments, we need to be able to look at these factors to see how it affects movement. There are extrinsic factors, such as the type of activities that we do. So what activities do we do? What is my job? If I'm a driver, it is going to affect my alignment. If I work in the factory, how does it affect my alignment? So all this should be part of what we assess when we look at the human movement system. Now, let me stop here and just ask if there are any comments or questions. I took time with that because I think that part is the core of our practice, because it brings out what our identity is, who are we? It brings out what our body of knowledge is. It also brings out the things that we need to do to be seen as physiotherapists. So I don't know if there are any questions or comments. Let me check them before we proceed. Please, those online, Ile, I believe you are, sorry, on YouTube. If there are any comments, just please pick them up and you can read them out to us, and then we'll engage those that are on the YouTube. I can't see any hands, or should I ask a question? Because I really want it to be interactive. Really want it to be interactive. Thank you, Abimbola. I'm happy that the message has been passed across. Because for change to happen, information must be there and it must be understood. And I really pray and hope that the practice will change as a result of this information and these interactions that we are going to have today. Well, I can't see any hands, so I will proceed. But please remember, it will be much more important if we are able to have the interactions. It's going to be very helpful. So, okay, I can see Nelson. Yes, Nelson Kalu, please go ahead, unmute and speak.
Thank you so much for the lecture so far. I actually interested in the two aspects that you brought up, talking about the pathophysiological aspect of our management and the kinesial therapy or so. So I really didn't get so much information about that. I need more light, because from what you said, when, for instance, someone is sitting for a very long time, that process of sitting that might provoke a condition, give rise to pain that may warrant you referring. But when you talk about having a pathology, is it the pathology that the medical doctor will refer for us to see, or is it what we identify that will also help us in our treatment place? Thank you.
Thank you very much, Mr. Nelson. So there are two pathways. Now, someone is okay, not having any problem, and then an infection just sets in. So those two different pathways or models, they are models. They are models of the body of knowledge, our body of knowledge. It depends on what sets in first. We are talking about the source. We want to treat the source. And therefore, if we want to treat the source, we want to know what sets in first. So if the infection sets in first, or there is a fracture, so fracture also is going to be a pathokinesiological model. An infection such as Poch disease or Pott's disease will be that. When you have meningitis, all these are infections that set in, and as a result of each of these pathologies or organic pathologies, it will lead into a movement impairment. So the person is going to have weakness, the person is going to have inability to do activities of daily living. What sets in is the pathology. And therefore, as a result of the pathology, you have someone having a movement impairment. The physician sees the patient first. Because if they have the pathology, for example, someone that has a fracture, they just bring it to you as a physiotherapist. What are you going to do to the patient? Unless if you are going to do fracture reduction, you are not going to deal with the movement impairment at that very point. Well, you can, because there's physio before surgery, there's physio after surgery. But whatever you do, you are not eliminating the source. So that's the important thing. I think the key thing there is eliminating the source or treating the source. So if there is a fracture, whatever physiotherapy you will do before or after surgery or before or after reduction is not eliminating the source. So who eliminates the source? The medical doctor. But when someone has movement problem sets in first, and that is why I talked about the sustained alignment, about the repetitive movement. Even if the person goes to see a physician, I mean, we have many examples of people that will have back pain. They will go and get pain relievers. They will come back, take it, they feel a relief. When the effect of the drug subsides, the pain comes back. Why? Because they go back to their lifestyle, which is movement related. So if you want to eliminate the source, it's the physiotherapist that will deal with the issue of ergonomics, or that will strengthen, for example, in the lower back, in the back, you have the multifidus muscle, it is not activated, and the patient wants to step on something, and the back will not protect, the multifidus muscle will not protect the back. And therefore, you will end up having an injury in the back beyond what was there in the initial stage. No matter how many drugs you take, pain wouldn't go. No matter how many surgeries you have, pain wouldn't go, because surgery is not going to go and activate the multifidus muscle. It is a movement-related issue. You have a muscle that is either not activated or a muscle that is hyperactivated. And therefore, the physiotherapist is the one that will come in, treat the movement-related problem, and if as a result of that movement-related problem, an organic pathology has set in, such as inflammation, such as tear, such as whatever it is, then you refer to the physician. So what we are seeing is that with pathokinesiology, the physician sees the patient, takes care of the source, which is an organic pathology-related source, and then refer to the physiotherapist, who sees the movement impairment as a consequence of the pathology. While in kinesiopathology is the other way around. The physiotherapist sees the patient, treats the movement-related problem, and then refers to the physician to treat the consequence, which is now the pathology that sets in as a result of the movement impairment that has caused problem to the patient. So I hope this is clearer. Yes.
Thank you very much. Thank you. Gotten it right, because I actually wanted to establish the fact that the kinesiopathology would also or could have a direct link to the pathokinesiology. There could be an interaction. It's just that for the first one, there's a pathology that is foreseen, which now gives rise to movement-related challenges. But for the ones that the physiotherapists are seeing, it is the movement that gave rise, or that may give rise to the pathology, which might set in. Okay, thank you. I got that.
I don't know whether it's your network or mine.
Thank you. I got you, Prof. Thank you very much.
Okay, fantastic. Yes, so let me add to what you have said. If you have a pathology setting, it their ankle, they have swelling, but it's in their back. So when people have Staples disease or any other, it's not taking place at all, that they now begin to have a pathology there. Or sometimes they may be vulnerable to have an. So you can see now pathology sets in, leads into movement problem, then the movement-related problem now leads into another pathology. So what you are saying is correct, that you can have the pathokinesiology now linked to the kinesiopathology. So they can link together. But what is most important for us in this understanding is that what is the source? At any point in time, as a health professional, you are looking for the source to eliminate it. Unless if you can't eliminate it, then you handle the issue of the symptoms. Someone that has end-stage cancer, and they say, look, you are going to die in the next two weeks. What we can do only for you is just to continue to relieve your pain until at some point, yes, I mean, the doctors do that. But if you can eliminate the source, go for elimination of the source. I want to emphasize this to physiotherapists. Let's not allow our patients to be discharging themselves because we are not eliminating the source. If we can assess movement, we can eliminate the source. And that is the main message of this. Yes, Dr. Imoru. Dr. Joshua Imoru.
All right, thank you. Well done, Prof. And good morning, everyone. Still on this issue of movement, the movement system and physiotherapy. My own view is you made mention of the importance and significance of a movement room. You said you didn't want to use movement lab, but okay, either movement room or movement lab. You have said that starting from next year, centers will not have a full accreditation if they don't have a movement room or lab. I will want you to probably what is a model of a movement optimal model of movement lab that you might be expecting, so that at least all of us that are here on the platform now, we have majority of us that are the management level, HODs, directors. So they will be able to know what they are expected to put on ground as a movement lab or movement room. Thank you.
Thank you very much. Very, very good one. And let me just modify what I said. You can't just release a new rule and then you just implement it immediately, you release it. I think I was excited and I said that, but it's going to start next year. But we can't say by next year, if you come for accreditation, we will not accredit you. Of course, it's next year that we'll release it and say these are the list of the things that you should have. And we'll say in the next 2 years, the rule will now begin to be implemented. But from next year, we'll start now encouraging them, advocating for them to establish those departments so that maybe in 2 years to come, everyone would have had it. So now, as I've said, before the end of these slides, you are going to see some of the things that you can do to assess sustained alignment or assess movement. These are very simple things that everyone can be able to get. But there are other sophisticated ones. For example, in my master's and PhD, I used what is called coda motion analysis system. Now you use reflective markers. You place markers in the joints, and then you have a camera on this. There are many different motion analysis systems. There's one they call Vicon. There's another one, OptoTrack. The one I used was Coda Motion. So the camera is now going to be picking the movement of that reflective marker in your joint. So whatever movement you do, that information from the camera will go into a computer. And then the kinetics and kinematics will be computed. The computer will tell you the degree to which you move, the velocity of the movement, the angle of the movement, the timing of the movement, every single information it will give you. Posturography is there. There's what is called force plate system or equipment. When you stand on it, it's going to measure the movement of your center of mass and also your base of support. And then it will compute your postural alignments, postural whatever, your balance and what have you. So there are many. When it comes to gait analysis, I know there is what is called gait ride. It's just like a mat, you walk on it, it has sensors, and then it sends onto a computer some signals about your gait, and then you'll be able to compute your gait. There's what is called Kinovia. Professor Ibenemi, I attended the workshop, and that is why when we said everyone must do workshops, some people say, no, I am this, I'm that, I'm big, I'm professor, I'm director, why should we act? I said, so I went, and when I went to Prof. Ibenemi's workshop, it was one young man, is it? I can't remember his name again. I will remember because he taught me, and he's Prof. Ibenemi's student, and the way he does that Kinovia. And Kinovia is something that's free. You download it. All you need to do is to learn how to use it. It's like free. You only need your computer, and then you need some sticks and whatever, the ruler that you do calibration. And then the patient walks. There's a camera that picks it up. You put it on the Kinovia, and you use it to do all those movement analysis of the patient. So there are many that are free. There are some that are of moderate cost. There are some that are very high cost. We'll categorize them. We'll say the ones that are free, you must have them for you to get accreditation. That's the ones that we'll say you must have because they are free. Or some that are moderate will now be say, now, our accreditation from next year is not going to be full or partial. We are going to have about 7 different levels. So level 2, another person will be at level 3, another person will be at level 4, another person will be at level 5. And we'll publish it. Say people that are at level 5, they have these expensive equipments that can do more sophisticated assessments than a person that is at level 3. And therefore, if you can't afford that, this is the hospital you go to. But if you can afford, you go to this hospital This is what it's going to provide for you. And let's not use the issue of affording or not affording. You just say that if you need these services that will provide this sophisticated information, because if physiotherapists need a more sophisticated information for them to be able to treat you better, this is the hospital that you should go to. That may lead into competition, that hospitals will now begin to invest into buying those expensive ones because patients will only come to their hospitals if they have them. So this is the plan. The scoring and the review of the guidelines has been done. By early next year, we'll call for a stakeholders meeting, discuss, present the list so that all of you will look at it, advise us if we need to change or adjust, and then after that, we'll release it. And when we release it, we'll now begin to implement maybe in the next 2 years or so. So thank you so much, Dr. Joshua Imoru. We are going to do that. We'll release the list very soon so that you'll see what it takes to establish the movement. Yes.
Thank you, sir. There is somebody sent a message to me that I should ask you to address the issue that is going on the YouTube. I don't know what issue, but a message was sent to me.
Okay, please ask the person to now summarize the issue going on YouTube and send to you. Then you can help direct it to Ross.
All right.
Yes, Rukaya, before I call you, just want to thank Grace. I'm very happy. That's the purpose of this training. Very happy that I was defining myself with what treatments I provide. But now this is going to change. Truly happy that that will happen. And let me encourage all the facilitators in the state. You know, one thing that I've learned, let me mention Mr. Anjorin, my very good friend. One thing that I've learned from him is that if you want to do things alone, you will only reach out to a few people. But if you empower 36 people, each person will go out there and empower 10 or 20. At the end of the day, you will see a revolution that no one can stop. So what I want to encourage our facilitators for this workshop, and I believe many of them or all of them are here. And of course, you have already attended the trainers. Please, when you get back to your states, you can continue with these workshops. It doesn't have to be the people that have signed up for this MRTB clinical pathway workshop or foundation workshop. Continue to do it. And please feel free. You don't have to even do it under the platform of MRTB. If you finish this one, in the next 2 months, advertise. Let 10 people come, you train them. Another 2 months, advertise. Let more people until everyone in the state has gotten this concept. Then continue to monitor to see that the practice is changing, because most of you are either HODs or senior persons, chief director, assistant director in your hospitals. You can use that opportunity to monitor the practice and see how it's changing. That way, you'll see a revolution. But if we not just keep it at this level, I don't think it will go out that much. I learned many of these things in 2013, and I've been doing workshops, small workshops. But at some point, God made us to think, okay, let's have it in all states. And I believe this is going to be the source of the practice changing, God willing. Rukaya Dauda.
Yes, sir. Thank you very much, sir, for this wonderful workshop. My own concern or question is that, is there going to be training to further broaden our knowledge on how to use movement system apps or gadgets before the implementation starts next year? Because at this point, it's not everyone that is fully aware of what the movement system app is and how to use it, sir.
Definitely there's going to be that. We have a schedule for trainings for next year. This clinical pathway training that we have been having for 2 years, we have an updated version where next year it will focus on the movement system, on the functional anatomy, on the use of gadgets for movement analysis. They are there. I was telling you about how I attended Prof. Ibeneme's workshop and I met a young guy that is very good in that. I had a meeting with him. We said we'll have a follow-up meeting. We have not been able to have it, but before the end of the year, we'll have, so that he can facilitate a workshop on that use of Kinovia. I can do a workshop on the use of the other sophisticated movement analysis systems, since I used them during my PhD, even though they are not available. But if we learn how to use them, by the time a particular hospital decides to buy it, we can be able to at least have the knowledge to use it. Then we'll now find out resource persons. For example, the ones that I will show you here, these are things also that I can facilitate. For example, CABA, there's one that's called CABA, clinical. Anyway, we'll see all of them before the end. But I assure you, there are going to be workshops lined up for learning about functional anatomy and functional movement, about the human movement system itself. Because what I've given you is just a little out of a lot that I just picked from the slides for human movement systems. So we are going to have all those workshops. And that's why I was telling you, I was correcting myself, that the implementation will not start next year, because we are going to now inform hospitals of what to put in place. We are also going to do a lot of training for our colleagues. It is only after that that we'll now begin to implement. And that is why I'm projecting about 2 years. It might be more than 2 years, but at least let's begin from somewhere. Yes.
Okay, thank you very much, sir.
Okay, thanks a lot. Thank you so much. Yes, Abimbola, in fact, the 2013 was when I learned it, because that's when I did my DPT with Michigan Flint University. But if you look at the slides, I think the APTA started this movement issue way before that time. So, the components of patient management, I think I've explained them. So I'm not going to dwell a lot on them, but just for clarity, when you say assessment under the components of patient management, what you are talking about, let me see if I have any slides explaining them. Okay, I don't have, so let me just use this slide to explain them. When you say assessment, any data you collect during your clerking process. So what I mean by that is your biodata, your past medical history. So biodata, you're asking age, this assessment. What's your gender, this assessment. Family history, has your father or mother had stroke, this information, right? So it's assessment. Family social history, do you drink, do you smoke? If you smoke, how many sticks? If you drink, how many how many cups of or pints or whatever of the drink? Now, when you go to your history, you're asking, do you have headache? Do you have swelling? Do you have symptoms? So the symptoms, you are asking the question and they are giving you an answer, this assessment. When you go to examination, you do your VAS. Okay, show me where the pain is. And if this is 0, this is 10. They show, this is assessment. When you take the weight of the patient is assessment. The height of the patient is assessment. Whatever you do, that is just a direct thing you do and you get a result or a record is assessment. Now, but what is evaluation? What's the difference between assessment and evaluation? Sorry. Dayo, exactly, Trenchard. Thank you so much. It's very good for me to mention Dr. Dayo. Professor colleague's name you are trying to remember is Dayo. Yes, Dayo from Dev Umahi. Young man, sincerely, but very talented. Professor Beneme groomed him. I was a participant in the workshop. And I was calling him sir. When I don't understand something, I'll say, sir, I don't know. I forgot that he's a young man. And he'll say, prof is calling me sir. I say, please forget it. Just explain it to me. So there are very, very talented young people that can teach us many things. I remember this guy that attended his workshop also. He was even an NYSC guy. What's his name in, what do you call him again? This young man is vibrant now. So I learned from him in National Hospital. But let's not get there. Let's Chijioke Otipa. Yes, so he too learned kinesiotaping from him. And I knew kinesiotaping, but I attended the workshop and I just saw new techniques that I didn't know about. There are young people that are really talented. So we'll have to just pick those guys that have done trainings. Muhammad Aliu Abba, he went for his master's in Poland. And he learned about PNF. And I attended a workshop. I know PNF, I'm in neurophysiotherapy. But this young man has learned something from that certification there that I learned something about. So there are many young people, very talented, good young guys. So we'll continue to harness those potentials so that all of us can learn from them. Yes, so evaluation. A typical example I always give about evaluation. Obesity is a risk factor of diseases. Now, when what assessment will you do directly? Say, okay, this patient has obesity. So if, for example, you have only weighing scale and you don't have other things that you use to directly know that it's obesity, you weigh the patient, you get the weight of the patient. You have standometer, you get the height. Now, this assessment, but does it tell you that this patient is obese? No. You have to interpret that result. And that is how someone came up with the idea of weight over height squared. You do weight over height squared, and the result that you get will now determine whether there is obesity or no obesity. So if you get less than 18 underweight, between 18 to 25 normal, between 25 to 30 overweight, above 30 or 30 and above obese. So this is now interpretation. And this is what is called evaluation. Getting the result is not enough to lead you towards what the patient problem is. What will lead you into knowing what the patient problem is the evaluation. And that is why evaluation is very important. Now, another example of evaluation. You have a patient that you ask questions about their age, say 60 years old, gender, and female. Do you smoke? Yes, I smoke. How many sticks? 10 sticks in a day, every day. Do you take alcohol? I take alcohol. How many cups or pints or bottles? This number of bottles. And are you physically active? No. I walk a little to the gate and come back, and that's all I do. Okay, you are sedentary lifestyle. And you ask all these questions. Each does not tell you what the problem of the patient is. But putting them together, you now begin to think that, look, all these risk factors that I'm seeing, they are risk factors of cardiovascular disease. And therefore, I suspect this patient has cardiovascular disease. Now, the question and the answer you get is assessment. Putting them together to suspect a system is evaluation. Now, we are going to see other examples of evaluation, but I'm just given that so that we'll understand the difference. Assessment, you just assess, you get the answer. But evaluation, you interpret, you make sense of it. So is evaluation same or close to clinical reasoning? It is the clinical reasoning that you use to do the evaluation. And we're going to discuss clinical reasoning and evaluation. We'll discuss them separately. Just the next few slides, you'll see that. So then diagnosis. Now diagnosis, there is what is called a clinical decision tree. Just yesterday, I put together something that I thought maybe a chart or a diagram that will bring out that information. So we are going to look at it. But when you assess and at some point you stop, you make and you do an evaluation, you make a suspicion of what the problem is, you then continue to narrow down until you get to the point that you can only rule in one condition. That is when you now have a diagnosis. So the assessment being evaluated will lead you to a diagnosis. Then for prognosis, now I just hope that I will not be giving you too much information that will not be assimilated. Please just let me know if you are not getting it, if you need a break, if I should slow down, if I should reduce the information. Please just give me feedback at any time, and I will try to adjust the way I present. So prognosis, from your assessments, the assessments that you did, there are some factors that you have. For example, severity of the condition, the age of the patient, and a number of other things that you will now look at it and say, based on this patient's condition and these factors that I've looked at, how long do I think it will take for this patient to recover? This is what prognosis is about. Meaning there are three things. But remember, we are not going to deal with prognosis or intervention. I'm just trying to explain them. And then when we get to the next slides, I will abandon prognosis and intervention and outcome and focus on only the first three that are on this slide. So prognosis, you are just looking at some factors that determine how long it takes to be able to have a recovery. So meaning you have those factors, very important, the time and also the type of recovery that you are looking at. Those three things are important when you are looking at prognosis. Then intervention is the treatment. An outcome of course, as I've said, when you have finished the intervention, the patient gets better, but when they go out into their community, they want to go back to work, can they be able to integrate back into their community? That is looking at outcome. Now, someone asked about clinical reasoning and evaluation. So let's look at the clinical reasoning. Do you want us to take a break, few minutes break, or should I continue? Just let me know, maybe through the chat forum. Continue, okay, good. Okay, that's fine. Thank you so much, well done. Yes, so let's look at clinical reasoning. Now, this is a lecture of its own. In fact, it's a lecture that will take for more than a day in our usual workshops that we do. From 10 to 4, we can't finish it. We have to have another day, 10 to 4. So I'm just going to just summarize it, but they are part of the schedule for next year. Next year's clinical pathway schedule that we have. So, but I'm going to just take a little time to explain what they are and how it can be used for evaluation that we're talking about. Now, there are cognitive processes. When you are in school, if, for example, in level 1 or level 2, you are taken to a hospital, you are given a patient. I say, okay, can you treat this patient? What is it? So clinical reasoning is about the thoughts that come into your mind. Usually the studies on clinical reasoning are done, you give a subject, a patient, and you say treat. Or you said, because I can't measure your thoughts. You know, if to say that there is a device that you will use to be able to know what someone is thinking when they are seeing that patient, you will have said, oh, I had you think of this, I had you think of that. You know, there are movies that you have someone, they can get into your, I remember the one, there's even a clip, I didn't watch the whole movie, it's a clip. She wanted to sign a contract, and all of them, the people that wanted to sign the contract with her, they keep saying there is a faulty relay. In fact, that's what I even remember. There's a faulty relay. Another person will say there is this problem. Another will say, but it's stupid. Just go ahead and sign. But the guy just came to deliver coffee, and he had all their thoughts. So before he went out, he quickly told her, he said, don't sign. And she said, why? He said, they are not telling you everything. And then now she asked, he said, who is this guy? And one of them says the ex-coffee guy, and he sent him out, but she followed him. So I'm psychic, I can hear their thoughts. So usually when you do a study for clinical reasoning, what you usually do is to ask people to think aloud. You say, whatever you thought, I want you to remember it, and at the end, I want you to, it's not Chinese. I can't even remember the names of the actors and actresses because I don't, well, it's just a clip, but it was interesting to me. So they asked them to think aloud. To think aloud means whatever thought comes into your mind, I want you to remember it. After seeing the patient, you now come and say, what came into your mind? What did you think? What was it that came to your mind as you are thinking? So that's how they do studies on clinical reasoning. So as the patient comes to you, what determines what you do to them? So the thoughts that come to your mind. So now, I was given an example with the student. The student comes, giving a patient. What will come to their mind? Oh my goodness, you have given me trouble. What do I know about medical field? I don't know where to start. I don't know what to do. That would be the thought of the guy there. But let them go through 400, 500 levels. They now come for clinical exam. When you give them patient, the first thing that will come into their mind is their class, the lectures they had. So, I remember Dr. Imoru during the clinic taught us this. He said we should assess this or we should assess that. You say, Dr. Chinwe Obikwe taught us that we should always ask about the patient's this or that. Say, Professor Kaka taught us that we should do this or do that. So that's what will be coming to their mind. Or another student will now come and say, I read in that textbook that when you are assessing a patient, you should do A, B, C, D. That thought that comes into their mind is what they will now begin to do. What they remember, if you taught them 40 assessments, it's possible they will only remember 5 or 10. That is why when in a clinical exam, you give them 15 minutes, and within 10 minutes, they have even finished. They don't know what to ask again. I would say assessment information you can finish, and that's what they can remember from the books or from the class, what they have been taught. This is what is called an analytical cognitive process. You are remembering what you are taught, or you are remembering what you read or what you listened to. But by the time you continue to do this, you see it on one patient, you do another patient, you get to the third patient. When you see 10 or 20, now all these our experienced people that are on this platform, they will tell you, when a patient comes and they see a gait pattern that is Parkinson or stroke, they will say, the last patient that I saw had similar pattern, and therefore I think this patient has stroke or they have Parkinson's disease. That thought that goes back to the experience you have had on another patient after seeing many with similar situations, similar characteristics. The next thing is that you now begin to think, okay, that process is called non-analytical cognitive process. So non-analytical cognitive process. I'm getting somewhere with this, and I will let you know how it helps you with a better evaluation. Now, let me ask if there is a gen at the back of my window, if it's disturbing you so that I move from where I am. If it is not, I will continue, but if it is, I will move to a quieter place.
No, sir.
Okay, wonderful. Okay, so that's good. So now metacognition. Remember I mentioned that it's possible that you may have been taught 40 different assessments that you do to a patient. But because you don't practice all of them, or maybe you have not even started practicing, you are just in the class, they mentioned 10 or 20 or 30 or 40, and you learn them, you thought you can remember them. When you come to the patient and you want to do all those tests, then you only remember few, maybe only 5, and you do only those 5. Now, a very clever person, after they have treated that patient, they will now go back to their books, or they will go back to the video of the lecture they have had. They will now say, which ones did I miss? Sometimes you go to a physician, after seeing one patient, you enter, you see them with a compendium of medical, whatever. They are checking. What they are doing is metacognition. They are saying the questions that I asked the patient. After some time, let me find out if I missed anything, so that when next another patient comes in, that I will be able to remember more and do them. Yes, pattern recognition, yes, because it's experiential. And you are looking at pattern, and then later you recognize it, and then you'll be able to recall that pattern. Yes, very true. Someone was asking a question about non-analytical process. So that's what metacognition does. And metacognition, you can do it yourself. Someone can look at your practice and say, you should have added A, B, C. You didn't do that. That also is metacognition. It could be a colleague, or it could be a senior person, or a teacher, or a supervisor. So that's it. So this is what it is. Now, in the slides, I'm going to show you some slides that will show information that helps you to be able to suspect if different systems of the body there's a problem in those systems or not. And I said it's evaluation. Now, with this clinical reasoning, if you want to truly do that evaluation, number one, you need to collect information. Without information, how can you interpret you can't interpret what doesn't exist. And therefore, you need to collect information. And the process of collation of information will depend on the cognitive process that you use. If you are a young guy that is just getting into the practice, very important to always remember your books. And if you want to make the process of collecting the information better, you do metacognition. Ask yourself questions, go back to the books, ask someone to give you feedback whether you are collecting the right information. You are an experienced person. You continue to remember the last one. But remember, you can be experienced in doing the wrong thing. And therefore, if you are not going back to your books from time to time, you will continue to build on something that is not enough, and you will think you are doing well. You are not doing well. And therefore, sometimes, even when you are doing non-analytical, you need to go back and begin to do analytical. This is important. Now, just keep that information until we get to the slides where we'll discuss the issue of evaluation. Another important thing about clinical reasoning that will help you with evaluation. There are two types of reasoning. There are many others, but I just picked these two because I think they are the relevant ones in the discussion that we're going to. There's what is called diagnostic reasoning, and there's what is called narrative reasoning. Diagnostic reasoning is when you collect the information, and the information you interpret it to make a diagnosis. But there's also information that you collect, but it is not going to help you to make a diagnosis. It is going to help you when you come to treat the patient, because they say rehabilitation is an active science. No two patients have the same environment. No two patients interact with the environment in the same way. And therefore, you need to know what you need to know about the patient that will help you to help them integrate back into their own environment. They can live in the same house, but this person likes sitting on a chair. This person likes to lie down on the sofa. This person likes to sit on the floor. If you don't understand them, you wouldn't be able to know how to rehabilitate them to get back into their community. So if you're asking patients your age, your gender, your smoking, you are trying to build a case for what system of the body is affected. But if you're asking the patient, what type of house do you live in? Are there obstacles to enter your house? These are questions that are narrative reasoning in nature, because at the end of the day, you will use that to be able to help you to plan the rehabilitation of the patient better. But diagnostic reasoning, the information you collect using analytical or non-analytical cognitive process, diagnostic reasoning is going to help you to be thinking about that information and say, okay, what do I suspect with this information that I've collected? As I've said, we'll see more of that in the next few slides. Because I know this is really sometimes confusing, please feel free. If there is anyone that's good in this area, don't ask me a question. If you are better than me in knowing these things, just please make a comment. Like in Prudence, Chinedu, I believe that question is not coming as a question, it's coming as an information, because it looks like someone that has experience in clinical reasoning. So please, anyone that has any comment to further explain this, please just go ahead and do that. Or if you don't understand it, ask a question. So let me just see if there is any comment or question before we proceed, because this is a very critical part of what we'll be discussing. Okay, metacognition is the feedback you get about your reasoning, whether you are doing the right thing. So if I read a book about risk factors, and I remember that I always use cardiovascular because it's a very common one that we have all those risk factors. We look at the age, we look at the gender. Age would be maybe elderly, gender, females are more prone to having cardiovascular disease. The smoking, not just smoking, but smoking many sticks per day, the alcohol intake, the physical inactivity, then possibly genetics. Can you see earlier, I forgot to mention a genetics when I was giving the example earlier, and also past medical history. Someone that has hypertension will be prone to having, stroke, for example, or any other cardiovascular disease. Sorry, but not stroke, heart disease, for example, heart disease. So what I'm trying to say here is, when you remember the books, you know, initially I was just mentioning age, gender, smoking, alcohol, and I was saying these are risk factors for cardiovascular disease. Now, I now sat down and I remember, I missed out genetics. I missed out past medical history. I missed out one or two other ones. When next another patient comes, I will not ask those first four alone. Because of the metacognition, I'm going to ask more of the things that I forgot in the first one. But if I don't do metacognition, I will continue to ask for only those four. Let me tell you something that I've observed. I'm not going to mention the hospitals. So feel safe if your hospital is part of it. I pick folders and you will see anectinic acidosis febrile, gross muscle power, TPP. Every single file of every single patient you pick, you see the same pattern, the same assessment, usually 1 or 2 pages. So meaning someone learned those things in school 10, 20 years ago, and they have trained other people, and everyone is doing the same thing. No one is going for training, no one is going for reading books to see if there are additional things they need to add, or maybe, for example, gross muscle power. As a time, I saw everyone would say GMP 3/5. And when you say gross muscle power 3/5, what that means is that maybe you ask the patient to raise their hand and you resist, or they can't resist, but they can move against gravity. What that means is just the shoulder flexors that are 3/5. Because you have not tested the wrist, the elbow, the shoulder, each muscle separately, you need a chart. So if you do gross muscle power, you don't have a score. You just ask the patient in history, do you have weakness? And they say yes, and they put their hand from their shoulder across to their hand and say, all over this place, you say gross muscle weakness. How can you have gross muscle power? Unless if you do the charting and every single muscle is 3. Then at the end, you can say all muscles are 3/5. But there is nothing like one assessment. I kept doing that. I myself, I was doing that at some point. But later I realized, how did I change my practice? It was through metacognition. I went back, read, and I got something new. I came back, I changed it, and I started doing the right thing. So that is what metacognition is all about. And as I've said, it can come through books, it can come through presentations, but it can come through a colleague giving you feedback. Whatever it is, you must continue to improve your thinking and your reasoning and the information that you have that will be used for the evaluation that we are talking about. Okay, so let's go to the next. Now, let's look at clinical features of disease. Because we are talking of clinical reasoning. And we said it's about the information that you have that you remember to collect. So, how do we collect the information? Let me talk about journalists. Imoni Amareri used to be my favorite journalist with AIT. I know many people will say Shun now, and some other guys, I don't know, maybe some people like Oseni or Ruben Abatu or whatever, but one thing that's common across board with all these journalists, you'll see that before they start the interview, that time of Imoni Amareri, they used to have a jota. They would write the questions they are going to ask. But now I can see them with their gadgets, IT, not maybe laptop or iPad or whatever. They are looking at it. It's not shameful to look at it to make sure that you ask all the relevant questions that you want to discuss there. It doesn't really make sense to say that I must commit everything to memory to ask my patient. You can have a template. You use the template to ask questions, to record them. What's important is at the end, you collect all the information that you need to collect. But another important thing is that there are some things that will help guide you as to whether you have collected the right information or not. You must have a plan. And what are those things that determine what information you collect when you want to make a diagnosis? The risk factors, the symptoms, and the signs of the disease. This is your guide. So if you don't know risk factors of diseases, forget it. You can't do any meaningful diagnosis. If you don't know symptoms of diseases, forget it. If you don't know signs of diseases, when you get to your examination, you don't even know what to test. And this is one of the reasons why our clerking is so scanty, because we don't have the information that is needed. And therefore, our analytical reasoning is very, very defective. And our non-analytical reasoning is built on a defective, and I'm sorry I'm using these words, very sorry, but I mean, what's there is there. What's not there is not there. If we don't have this information, we just don't have this information. If we need to build, we need to go back to our books and begin to read about what are risk factors, what are symptoms, what are signs. You can't do any meaningful clerking if you can't remember all these things. But that's number one in clinical reasoning. Knowing what data to collect. How do you put together the data and make assumptions at the beginning and then later confirm the assumptions? Or suspect the presence of a disease, then continue to build a case until you confirm it is there. It is this basic information. Now, how do you collect data about risk factors? If you read about risk factors of diseases, you'll see that either it's talking about the age. Say if you are 60 and above, you'll have cardiovascular or neuro conditions. If you are 35 or 30 or below, you are more prone to having musculoskeletal problems because that's an active age. Gender. I forgot to put gender. They are very important. Gender. Females more prone to having cardiovascular diseases, maybe some cardiovascular diseases, but males are more prone to having musculoskeletal problems because of the nature of work and what have you. Social history, family history. If a parent has a disease, the son is more likely to have that disease. That's a risk factor. Social history. If you smoke and you take many sticks per day, you will be prone to having some system diseases. Alcohol, sedentary lifestyle. All these are social histories. They are risk factors. You are at risk of having one disease or another, or one system problem or another. Past medical history. If you have had pneumonia as a child, you will be more prone to having bronchitis as an adult. For example, drug history. There are some drugs that you take that make you prone to having a particular disease or problem. So all these are issues that until you know that information and you need to collect that information, it's going to be very difficult to collect that information. Now, this is very important to remember. Risk factors, biodata, family history, social history, past medical history, drug history. Because there's something I want to bring out of this. When we get to the template, APTA template, as it differs from our own template. Another very important thing is when you collect all this data, at the end of the day, you hardly ask or suspect a condition. You won't say that I suspect this patient has stroke or this patient has Parkinson's disease at this point, because these are risk factors that are there across conditions within a particular system. And therefore, what you usually do at this point is to suspect a system that I think the musculoskeletal system may be affected. I think the cardiovascular system is affected. I think the urinary tract is affected, urinary system is affected, and all that. Symptoms. So what do you feel? What do you see yourself that you are reporting to me? You take this information under history. And after the risk factors, you suspect a system. So for example, you pick, say, a neurological system. Now, under symptoms, you are asking about symptoms of neurological system. Do you have weakness? Do you have abnormal sensation? Do you have dizziness? Do you knowing those symptoms that are listed under neurological system, that you now begin to ask those questions. Do you have this? Now, back to the journalist. If you don't have this plan, the patient, you just say, okay, what happened? We'll begin to tell you a story. And I went for examination and I saw that students were focusing more on what happened. But how can what happened give you a diagnosis? I fell. Then what happened? I went to a clinic close to our house. Then what happened? Then they now referred me to a teaching hospital. Then what happened? Then the physiotherapist now began to see me. Then what happened? How can that give you a diagnosis? just history of what happened. But we are talking of history of the symptoms. Do you have weakness? Yes, I have weakness. When did you begin to feel that weakness? How long did it take before it reached maximum? Do you have any cognitive problem? Meaning, have you lost your memory? Do you have this? Do you have that? You keep asking those questions. At the end of the day, this is what will help you to narrow down from a system to a category of system within that particular system. And we are going to also look at that, how we can do evaluation under history. Then when you finish with your history, under risk factors, you suspect a system. Under history, you suspect a category under that system. Then under signs, what are those signs of that category of condition? You don't have to go into others. You can narrow down your assessment only to that category that you have suspected. You now begin to do this test, or that test, or this observation, or that observation. With that, you continue to narrow down from many conditions to a few. Maybe you will say 3 or 2 or 1. Well, I need lab test. I need a radiological investigation. And therefore, at this point, it's not conclusive. You say, this is my impression. And for people that use impression at the end of everything, wrong. You can't have an impression after you have done all your assessment. That's not a diagnosis. You can't treat an impression. You treat a diagnosis. So you only have an impression when after today's work, I've assessed, but I need more data before I make a decision. And therefore say, okay, let me request for radiological investigation. Go and get this and come back. Then when they come back, say, from this and what I've done yesterday, I've gone beyond impression. This is my diagnosis. You now put the diagnosis. It's the diagnosis that will determine what treatment you are going to give to the patient. So this is the process. And as I've said, I have a chart or a graph or whatever it is that's called that can explain more of this process. It is called clinical decision tree. But you use the clinical reasoning to do an evaluation. And at the end of the day, you reach a diagnosis. Another thing very important before I ask if you have any questions or comments is one of first thing, or maybe our hospital has made us to believe that you cannot request a radiological investigation or lab test. Wrong. But where, in what situation do I request for a radiological investigation? I'm assessing the patient. I do a systems and I suspect, I see a red flag. I suspect that this patient has an organic pathology. For example, I have low back pain. Now, your urination, is it painful? No. Is it the color? Has it changed? Oh, yes, it has changed. Okay, there's blood in it. This is a red flag. Straight away, red flag. Will I be asking the patient to go and do a radiological investigation to confirm a diagnosis of urinary tract problem? No, you don't need a radiological investigation because you have a red flag for an organic pathology, and it's a straight referral. It is the physician or the urologist that is going to do the radiological investigation to now get a diagnosis. But you are building a case and you suspect that there is maybe SIG dysfunction, something that is movement related. And at the end of the day, you said, well, for me to be able to rule out something and rule this in, or to rule this in, let me request for a radiological investigation. Go ahead, get it, because it's going to help you. What you suspect is a movement impairment. You want to rule in or out to confirm that? Go ahead, ask for it. Where you don't ask for it is where you have red flag for organic pathology. So don't go ahead and ask for any investigation. Let the person that will treat that organic pathology go ahead and ask for that investigation. So I just hope this is clear and it has this distinction between what we can request for and what we can't request for. So let me ask if there is any comment or question before we move to the next slide. And please, at any time that you feel we should take a break, just let me know. Okay, I can't see any hands, so I will continue. If next time I don't see hands, no comments, I'm going to be the one asking the questions. Yes, Chidera, you want to say something?
Yes, sir. Good afternoon, sir. Thank you so much for the lecture so far. So I went on YouTube to get screenshots of questions and comments from people, from the participants. So I don't know if it's okay. I want to read out some of them.
Go ahead. You read them one after the other, so that will be answering them.
Okay, sir. All right. First here says, how does the integumentary system really play a role in the movement system?
Okay. Number one, let's say, for example, you have bones and it's just superficial. It does not go into the muscles, meaning the muscles can still contract, they can move. But because of the bone in your skin, you'll see that the person will have restricted movement. So meaning it's not a direct thing. It's just like this thing. It's just because it releases those the substances that go in there and they do the chemical reaction that bring about movement. So the same thing with the integumentary system. It might not be a direct thing. The skin will not contract to bring about movement. It's not an effector, but it covers the muscles and it has a direct relationship because it is attached over it. And therefore, if it is tight, for example, so if you have a scar and the scar is tight, you'll see that movement will be restricted because of that scar. If you have an infection in a muscle, maybe not bones now, that also will affect the movement. So anything, any system that in one way or another, it affects movement is part of the human movement system. Either it brings about the movement or it restricts the movement from taking place. So if you have a problem in the skin, if you want movement to be unimpeded, then you have to deal with that problem so that movement will. So that's what I was telling you earlier. Your problem now is not about the organic pathology. Your problem is about how that organ or system affects movement. Since you are a movement specialist, anything that affects movement is your problem, and therefore you are going to handle it. Yes, next question.
Okay, thank you, sir. Then the next here is by Dr. Chinwobi Okwe. She says, is it not possible to make these trainings mandatory across the physiotherapy profession? So I guess that was the introductory part when you gave a brief introduction before the main lecture, where you talked about the DPT thing, transitional DPT, and the changes that will have to happen in mode of practice.
Thank you. If you look at the system in the past, it was that you just bring 30 CPD. It doesn't matter where you bring it from, and you renew your license. And it was a good thing because at least there is a system that says you must do a CPD. But then recently, the system changed and was even more restricted. That said, you can't just bring CPD from your, what is it that I usually call it, your, where you are more comfortable to do CPD. Now we said you must bring practice, 10% theory, 15% hands-on. You must bring leadership and management. You must bring this, you must bring that. Now, this is the first step. Next will be that even within practice, these are the areas that we want you to do. If you do one section this year, next year you must do another section. Another year, so maybe in the next 5 or 10 years, you can't continue to do within just one area. Now, this is something that we can do. But to make it compulsory that every single thing you must do it, just like someone in school must do everything, might not be may not be feasible. But what we can do with what we are doing now, the best way to have people do things is to motivate them, to show them the justification, show them how important it is to them and those that they treat, and do a lot of advocacy. People will pick it. Because believe me, if you make it compulsory and you say everyone must do everything, at some point people, just like I had sometimes back when we said 60 CPD, what made us to change it was that people said, force us. We'll go online and we'll just leave and do our own thing. And at the end, you give us a certificate, we renew our license. So, but that's when we now created RCF. Actually, I'm happy that you are here. You are leading one of the BCP. That's how it came about. We said, okay, let's bring people from each state. Let's show them how important this is. They are the ones that will go back to the states and talk to people so that people will not embrace it themselves. They are not being forced. And this is a challenge to everyone that is here. When you go back, tell people how important it is. We don't have to force you. We want your practice to change. That we want to feel that people to respect you, to say, this is a professional. The only way is if our knowledge and skills are upgraded what they should be. If our identity is projected from our experiences, not just our speech. So I think that's just what I would say about it.
Okay, thank you so much for that. The next is, I'm trying to report this because I think there's a typo here. So thank you for this wonderful presentation. My suggestion is that it's better for physio students to be taught more on functional anatomy, especially in level 2.
DPT. DPT, the BMAS, before CCMAS, in BMAS, I know there is clinical anatomy and clinical physiology in 300 level, maybe first semester or so, or second semester. 200 level, you'll do anatomy, you do physiology. But when you go to 300 level, you now begin clinical anatomy. And that is important. I was part of the committee that came up with the blueprint then. I remember the reason why we included clinical anatomy. We said, you do anatomy just origin research. In clinical anatomy is going to be anatomy about how the anatomy relates to functions, the activities of daily living, that we do, all that. So I think what we'll do, look at the CCMAS. If it doesn't have it, we now from the board have our to say that if you don't do it in the degree, your students finish will not start. They take a course before. So it's actually there's a lot to do. Believe me, there are many people that are supporting us and get there as.
Okay, thank you, sir, for that. Then the next one says, sir, please, can you explain the difference between pathokinesiology and kinesiopathology again?
So I know possibly this question came before Nelson asked, but let me still go over it a little bit. Now, pathokinesiology, you have a pathology, an organic pathology. And when I say organic pathology, I've explained earlier what I mean. I said the body of knowledge of the medical doctor is pathoanatomy. So you have a tear in a muscle or a ligament or a tendon, you have breakage in a muscle, or you have inflammation, fluid accumulating anywhere in the organs of the body or the structures of the body. This is what is called pathoanatomy, and it is what is called organic pathology. These are things that are dealt with by the medical doctor. Now, but for us as physiotherapists, what is important to us, our body of knowledge, is the movement-related problems. And that is why there must be kinesiology. There must be kinesiology. It's not about the muscle. What's the structure of the muscle? It's not my primary problem. It's a problem to me if it affects movement. But if the structure does not affect movement, swap the insertion and the origin of the muscle in as much as it will give the same movement. I don't have any problem. Let it just go and continue to be the way it is. But to the medical doctor, his problem is the muscle. Is there infection in it? Its structure, the way it is, and is there any breakage in it? This is organic pathology. But for me, it's about the movement. And therefore, indirectly, the muscle can affect the movement. But what matters to me is that, is it a normal movement? Or has the infection led into abnormal movement? Has the degenerative changes in the muscle led into abnormal movement? This is what matters to me most on my own side as a physiotherapist. So if you have the organic pathology sets in, and then it brings movement impairment, that is pathokinesiological model. Because the pathology sets in first, And if you want to target the source, the medical doctor is coming in to target the source. You give antibiotics to take care of the infection. I give surgery to reduce the fracture, which is a breakage. Or do surgery to make sure that the muscle tear has been taken care of. And then the physiotherapist will come in and now treat the movement impairment that comes as a result of the pathology. This is what is called pathokinetic model. But the kinesiopathological model, it is the movement-related problem that sets in first. Sustained alignment, sit for a prolonged period. Use your phone in an awkward position. Use your computer without ergonomics. Pick an object, it leads into a problem. Whatever it is that is movement-related that brings about the problem, and then later, because of that movement-related issue, you have now a pathology, an organic pathology. So sustained alignment could lead into tear of ligaments. When you pick an object, picking the object could lead into prolapse. That still is a kinesiopathology because it is the movement that leads into the annulus fibrosus tearing and the nucleus pulposus moving out of it. So that's a pathology, organic pathology, but what brings it about? It is the movement. So you can have a surgeon work on it or a medical doctor give drug. If the patient goes back and pick again, they will still go. So the source is movement related, and therefore the physiotherapist will have to handle the movement related problem, and then the physician will handle the pathology. So that is kinesiopathological model. So who refers first? Patho is kinesiology. Medical doctor sees are referred to physiotherapist. Kinesiopathology, physiotherapist sees the patient and then refers to the medical doctor.
Okay, thank you so much, sir, for that. That was really very easy to understand. All right, the next question we have here says the issue of movement, okay, more like comments, the issue of movement should be more thoroughly explained. Can we have an idea of what is expected?
Okay, so I think maybe this person is referring to the movement, human movement system. So the most important thing is to understand how movement comes about. We said we have the effectors. The effectors are the ones that affect the movement. You have the muscle contracting. It moves a bone at a joint or at joint. So this is the effector, which is the musculoskeletal system. Of course, if we are talking about the heart, it has muscles and it's going to contract. And when it contracts, it will take blood out from the heart to the body. And the same thing with the lungs. It also has muscles, contract, and it brings in air in and out of the system. So that's musculoskeletal. That's if it is in the periphery, but you also have the muscles of the heart and the lungs. They are all effectors. But you have the nervous system that directs the muscles to contract and guides them when to contract, when to stop. And therefore, it's like a regulator, the nervous system. Then you have the pulmonary system and the cardiovascular system. They support the system through bringing in oxygen and blood that helps with movement. Sorry, just give me a second. Family, I think I can put back in option. So we travel a lot. I've been away for 2 or 3 weeks. So whenever I'm around, she wants to just, I'm not in the office because I know if I go to the office, it will be more trouble because I've been away for 2 weeks. Every officer will want to come get a signature or something. So bear with me. Sorry. Yes, so these are the systems. We have already just discussed the issue of the integumentary, how it comes in, and also so as a physiotherapist, you need to understand each and every part of this system. So for each system, musculoskeletal, you need to understand the muscles. You need to understand how they operate. The neurological system, how does it control the musculoskeletal, the cardiovascular. So your understanding of muscles, your understanding of pattern of movement, your understanding of what influences the movement to be normal and not to be normal This is what makes you a good physiotherapist. If you can't understand movement, then how can you be a movement specialist? As I've said, this lecture is not aimed at giving detailed information about movement. But we are going to have almost a month of training on human movement system on its own, and about a month training on functional training or functional movement. Is there. Before the end of this month, I assure you that the schedule will be released so that you'll be able to look at it. And now for next year, we have completed launching of our e-learning platform. And what they are doing right now is just to complete the process of linking it to what the PayPal, I think, yes, that payment platform. In fact, they have even tested it. They made payment and it has accepted. We have asked them to increase the capacity of the e-learning platform so that it can be able to take as much videos as possible. So what we are going to be doing now from next year is to have two versions, because people managing the e-learning platform, especially facilitators, that they are not just coming on a Saturday to give a lecture and go. They are going to be there for a week, monitoring what you do, giving assignments, moderating discussion boards, and doing exam and marking them. You have to pay them more than what you pay them with the 1,500, 3,500 that people pay. So we are going to have two versions. You can have that version that has already been running because you don't have enough funds. You pay 1,500, 3,500. You only do a 5-hour or 4-hour lectures. You get your certificate that shows 5 CPD. Or you can opt to go for the full version, where for every week you are going to have videos uploaded. You will read them. You will do an assignment, submit. You will go to a discussion board and you make comments on a particular topic of interest. And then at the end, you will do a quiz or an exam. Your results will determine if you get a certificate. And because it's a week-long activity that the facilitators will have to facilitate and coordinators will have to monitor, the payment will be more than that 3,500 that we have. But then this CPD point will also be much higher. Maybe it might be, say, 15 or 20, depending on the number of hours you are expected to spend in a week. So next month, that will be activated. And all these courses that you are talking about, they will be up there. So that you can be able to choose whether just to have the synopsis for one day or whether to go through the full version and do assignments and do exam, do discussions. And at the end of the day, you'll come out with your certificate that shows that you have competency in the area. So this will be available from January.
Okay, thank you, sir, for that. Maybe after this question, if you don't mind, we can continue. Then in between, we'll continue again. This question says, what if the source of the problem cannot be eliminated in the case of neuro cases? How do we manage?
Well, I've told you, if you have a cancer, the terminal, you can't even tell you. So there is what is called recovery, and then there's what is called compensation, especially in neuro. For example, if you have a stroke and it affects only a small area of the brain, that is what is called redundant cells. So those redundant cells will take over the function of the dead cells. But if you have a very huge area that has been affected, it's more difficult to bring in the redundant cells to take over the function of all the cells. And therefore, your prognosis will come from those factors. That's why earlier I was telling you about the severity, about this, about that. You will hardly not have an improvement because there's what is called interhemispheric lateralization, that you can even move from one part of the brain to another for function of that brain to be supported. So if your prognosis will determine whether you are going to have, if someone has an amputation, I mean, you can't think that they will be able to have activities without that limb unless if there is a prosthesis. Therefore, there are limitations. You can either have recovery, even the recovery can be full recovery or partial recovery. And then you now begin to talk about compensation. So your prognosis is what will determine distance. As I've said, prognosis is not part of our training for this course, but we are going to introduce it because it's something that we don't do very often. And we're going to have a workshop just on prognosis, but that will be in 2026.
someone asked it. Grace,
Sorry. Excuse me, sir. Can you please increase your volume?
oh, really?
Yes.
That's why
Your
someone
voice is
asking
so
whether.
faint.
Okay, so can you hear me better now?
Yes, much better now.
Okay, good. Sorry, I think maybe I pushed the system away. I didn't want to use earpiece. Sometimes the earpiece will not allow the voice to be well. Okay, so that's okay. Chidera, can we continue, or do you still want us to take comments or questions?
Okay, let's take this one more, then we can continue. Okay, this person asked, thank you, Prof, for this presentation. The transition DPT, I am just curious to know that the practice should be in two ways approach when it comes to referring patients from DPT to a medical. That's it.
Okay, so I think that's a comment. That's a comment. That's how it is. Sincerely, if we really build our capacity very well, that is what it is. Patient comes to you directly, especially those that are knowledgeable about what movement impairment is all about. And this is where we do a lot of publicity, educate people. And as a board, we can support the professional. If we say this is the scope of practice, no one can dispute it, especially because the DPT has it in it that you can be able to be first contact, even though it didn't say first contact, but whatever is required of the first contact is there. So we have a backing of a law. Our act says we determine the standards of skills and knowledge and skills. We are the ones that should determine the scope of practice. If we determine the scope of practice and then we advertise and then professionals do advocacy, let people know that if you have a movement-related problem, come to the physiotherapist. Why? Very good justification. Assesses you. He will now send you to the physiotherapist. You then pay and you will wait to see the physiotherapist. Meaning you are paying twice, you are waiting twice. But if you are coming directly to the physiotherapist, you are only going to pay once and you now wait only once. Especially if you are very sure that the problem is a movement impairment. Go to the physiotherapist. Why not to go to a doctor that will just give you pain relievers and then send you to treat the source of the problem? So we need to do a lot of education so that people will now begin to understand what condition they should have to come to a physiotherapist, what condition they should have that they should go to the physician. But over time, the first thing now, most important, let's even understand it ourselves. Let's get there. So if we get there, then we'll now begin to go to the public and make them understand. I said the voice is still low. I don't know what to do. Okay, let me check. Maybe. Okay, I think I will just move it very close to me. If you still can't hear, just let me know. Or maybe my voice has gone down. I don't know, but let me just see what will happen. Okay, so can we proceed? Is the voice okay now? Chidera,
Yes, sir. Your voice is very okay, sir.
Is the voice better?
Yes, sir.
Okay, good. Please, at any time that you can't hear me, just let me know. Now, this is the clinical decision tree that I was telling you about. Don't mind the spelling of decision. Now, if a patient comes to you and it's first contact, so we are now talking about first contact. First contact. If to say we have time, I would have asked you how you do assessments now. But let me still ask, even if it is just a few from your experience, apart from facilitators that we had meeting in the board, at the board a few weeks back, apart from you, any other person, when you, and please just look at the reality, how you do your own practice. Let me give you a clue. You have your biodata. You have, okay, let me just take it out of this. We'll get back there. So you ask biodata, you have your chief complaint, you have your past medical history, family social history, drug history, you have your history, you have your examination. So these 7 things, they can be in any different pattern. Let's say maybe you start with your examination. You take history, you take your biodata,
you take your family social history, you take your chief complaint, and you take your past medical history and drug history. Maybe just 3 people. What pattern do you use now? So just maybe three people, please. Let's make it interactive. There's a reason I'm asking for this, because that's exactly what we did when we had the trainers. So let's also engage you. Those on YouTube can please look there and see if there is any pattern that has been posted, so that you let us know on this platform. I thought every single person here is a clinician. So yeah, at least everyone sees patients. I can't see any hand. Or maybe you still can't hear me. Aha. Chidera, go ahead.
Okay, thank you, sir. Depending on what my patient is presenting with, if it's low back pain, most times after assessing and I'm able to rule out. Okay, when after getting the subjective history, what I usually do is that I start with McKinsey if it's a case of back pain. And if after that, and the patient has complaint of radiculopathy, if after that and my patient is still not, I'm not able to use McKinsey to handle my patient case, most times I now try to check for muscular factors like tightness of the hamstrings, like piriformis syndrome, or even hip pain or other things that can masquerade.
Okay, so let me say that before you think of treatment at all, don't even talk about treatment. This patient just comes and you are going to clack the patient. In the pattern of your clacking, what comes first and what follows?
Okay, what comes first? Okay, do I continue answering or is for
Yes,
some
you can
other
continue.
thing?
You can continue.
Okay, thank you, sir. When my patient comes in the first time, what I usually want to know is, of course, firstly, the presenting complaint. And depending on what my patient is complaining of, usually they'll always say if it's pain, you want to know the cause. You want to know the cause. That's how it's followed. You want to know how long. You want to know aggravating factors, relieving factors. So try to find out those things. And of course, depending on the location of the pain, most times I also try to ask some questions to rule out systemic causes. For example, I try to find out if my patient is having ulcer, because that can also come and present as low back pain. I also try to, if it's a patient that is having shoulder pain, I also try to ask questions about chest pain. So while I'm asking, I try to also ask questions about systemic issues, systemic pathologies that can be presenting as, pain.
Thank you so much. That's a good one. So Rukaya Dauda. I thought I saw Kara. Is it Kara? Kara's hand, right? Yes. But let Rukaya speak first. Rukaya, go ahead.
Okay, when I first see a patient, I first ask the patient, the chief of complaint, as you have said. Then after the chief of complaint, I will know as how he has said it, okay, this is what is wrong with me. Let's take maybe knee pain, for example. Then he gives it, then I will ask him for how long he has been having this knee pain. Then I write the time in front of the chief of complaint. Then I continue with the history, telling me everything that occurred, what happened, when did he start feeling the pain and everything. And I try to get the alleviating factors and the aggravating factors of the knee pain and what type of pain it is and when usually is this pain intense or more. Then after that, I go to my past medical history, the past surgical history if ever done. Then I go to family history, the drug history. Then before I commence with my assessment. Also, even the observation, I'll see how he came in, how was he having an antalgic gait. Also, I'll document every observable change I've seen with him before I proceed to the assessment. And on the assessment, I'll palpate the area and everything before I start doing my special tests to check what really is wrong with the knee before I now go to my functional abilities or limitation analysis of findings. Then if I need to do a muscle chart also to see which of the group of muscles is weak or not.
Thank you so much. Okay, yeah. So that's a similar pattern with little changes, adjustments. Thank you so much. Okay, yeah. Kara, I hope I'm pronouncing your name correctly.
Yes, sir, you are. Thank you so much, sir, for the presentation so far. So my pattern is almost similar to that of Rukaya. However, my assessment actually starts with the client coming in. So it depends. Sometimes if the client is already seated, because sometimes I also do home care. If the client is already seated before I come in, I would note that. But if I'm seated at the office and then the client comes in, the first thing I begin to do is I try to note how they come in. Were they wheeled into? Did they come with crutches or an assistive device? It just gives me an idea, kind of what it doesn't really pinpoint anything, but it just tells me that okay, maybe this person, whatever it is that this person is having, maybe it's limiting their movement or whatever. So when they come in, the first thing is their bio data. I ask questions, age, and the like, as from Pitiruka I already mentioned the bio data, the age. Then after I've gone to the bio data, then I ask them what is their concern of coming. So that's their presenting complaint, and how long has the presenting complaint stayed. I usually most times see mostly geriatric clients, mostly. So most times it's always going to maybe I've not been able to stand, I've not been able to walk. So then I ask the duration. Then I go down to asking the history. When did they start? Was there a history of fall, or did they had any condition? After I've gotten the history will enable me ask other questions in that regard, maybe based on what the client is presenting with. It would not help me to ask, um, is there anything making it worse, aggravating it, or what happened before then? So after that, I'll just go to the medical history, if they have other comorbidities they're managing, and just as then continue the surgical histories and then their drug histories also. And the social history, do they have support? As I mentioned earlier, I usually see mainly geriatric clients. Do they have support? So what is the system that they have to navigate? Then I'll go down to their vitals, uh, then begin systemic assessment or sometimes segmental assessment, depending on what is it. But most times for me, because I generally see geriatric clients most times, I usually used to also assess more like their cognitive function. It's something that I do personally. I usually used to assess their cognitive function and their nutritional function. I don't know if it's related to physiotherapy, but it's something I do personally, the cognitive function, their nutritional functions, and then go further to now specify function physiotherapy assessment, uh, go in details, the upper limb, the lower limb, or if I'm using system, I'll use the musculoskeletal system, the cardiovascular system, then their functional activities and what they can do. And sometimes and I use outcome measures, priority skills, and the likes to continue my assessment. If need be, request for radiological imaging after I've gone through. This is what I can functionally see from the client. This is what they are able to do. This is the analysis of findings. Then if there is a need to go for a radiological imaging, and I will request for that to confirm whatever it is that is ongoing. So that's largely how I carry out my assessment.
Very good. Very good. Thank you, Kara. So I'm going to take the last two, Zainab and Edna, but please let me plead with you because of time. Stick to the sections. So just put the the pattern. Is it biodata, family social history, chief complaint, drug history, then the history examination. So just the names, so that we can move to the next part of the discussion, because we are still going to have a discussion around these issues. So what I've seen now is a similar pattern from the 3 or 4 presenters. Let's take these 2, and then I will present a different one, and then we'll discuss the 2 to see which one I will best use in Nigeria. Thank you, Zainab. Zainab, you need to unmute.
Good morning, Prof.
Yes, morning.
Thank you. Thank you for the presentation. Sir, from what we were given here, the risk factors, the symptoms and signs. So the first thing that will come into our mind is the patterns in clinical decision making. So firstly, you go for the analytical pattern, then the non-analytical pattern, then the metacognition. So after adding all these patterns in clinical decision making, I think one should be able to handle the case. Thank you, sir.
Wonderful. Thank you so much. Very true to always remember the issue of the analytical, non-analytical. Because what we are talking about, we got it from the analytical, but then we keep doing it, we get to the non-analytical. Metacognition will help us to cement whatever it is that we need to do in a better way. Yes, so Edna. Edna, you need to unmute. Okay, Edna, okay.
Yeah. Yes, sir. So, for me personally, I think in the past I used to use the chief complaint pattern after taking the bio data, and then move to the history, the past medical history, family social history, and all of that. But from the end of 2023, after getting so much relearning done, because we had to unlearn some of those patterns, and right now we are currently also training students. I have tried my best to also move to the other side, where we don't ask for, after the bio data, we don't go straight to the chief complaint because of the tendency for bias. So we try to do the systems and review. I think I have been very intentional from last year now to 2025 to see how we can move away from the old pattern. It's not easy, and sincerely, the system screening takes a lot of time. But I believe that is something that we can still do, given that the assessment process is supposed to be an ongoing process. So it's doable. Thank you.
Okay, thank you very much, Edna. So that's metacognition. Of course, this Zainab that was mentioning the issue of analytical, non-analytical, the pattern. So that's what you did. You did the analytical, and then you now helps you with metacognition that now helps you to go back and change the practice, and it's now becoming a more of a non-analytical with the right pattern, as you have just said it, to avoid bias. So thank you. So I think all those that have spoken, including you, Edna, that at some point, the pattern has been biodata, chief complaint, history, and then the other histories. At least, I know after biodata, almost all of you, after biodata, you ask for the chief complaint. So that has been the pattern. And this is the Nigerian pattern. And it is a pattern that came from the time we had a BSc.
Excuse me, sir, your voice is low.
Oh, still, I really don't know what's happening. Maybe it's the speaker. Is it better now?
Yes, it's better now.
Okay. So I have to put the computer to my face. You know, the eyes have gone. I don't have glasses. So if I put it very close, I can't see. If I put it far, you can't hear. So I will have to.
Yeah, sorry, sir.
During the break. Yes, I assure you during the break, I will get a solution. But
okay,
for now, let me move it very close to my face. So yes, now the system we have from the BSCPT to BPT is a system that you are expecting a referral. Now,
someone would have taken care of underlying diseases. You remember in my introduction, right from the beginning, I mentioned the issue of you being able to assess holistically so that apart from what is within the scope of your practice, if the patient has any ailment that is organic pathology or that is out of your scope of practice, you are expected to identify it, suspect it, and then refer to the appropriate professional that will see that underlying pathology. Now, what this means is that at the end of your clerking, you can make one of 4 decisions. Number one, you only identify a case within the scope of your practice, so you keep the patient and you treat. You identify a case that is within your scope of practice, but you also identify another underlying disease that is not within the scope. Ask the patient to see a professional that will treat the underlying disease, meaning both of you are going to keep the patient and treat the 2 different problems that have been identified. Number 3 is when, after your assessment, you realize that the patient does not have any problem within your own scope of practice. For example, the patient came to you because they have low back pain. But when you do your palpations during the examination and you do your movement of the back and the pain does not change, you now ask the patient, do you have your urination? Whether it changes, whether it has color, whether it's painful, and you realize that there are signs of urinary tract infection, which can refer pain to the back, meaning it's not local pain in the back. This is an organic pathology from the urinary system that is referring pain to the back. And therefore, you don't have to keep it. You send the patient to a urologist. So that is the 3rd case, where what you find is not within the scope of your practice. You are referring to someone. It's possible that you will have information not available to you, and therefore you can't proceed. And therefore, you will want to consult another person to get information to clear or rule out or rule in conditions. And that is what is called to consult. So you have those 4: keep, refer, keep and refer at the same time, and consult. Now, for you to be able to take a decision about one of these 4, now as someone that is a first contact practitioner, if you are not a first contact practitioner, someone would have done that screening for you. And therefore, when the patient comes to you, you can ask the chief complaint after the biodata, because you are only after knowing what brought the patient to you. And therefore, you now go ahead and do your examination and you treat what brought the patient to you. But with the first contact, the moment you ask the patient about their chief complaint, you will be biased. If the patient says, I have low back pain or I have shoulder pain, you are going to have all questions aligning with musculoskeletal. And if there is a urinary tract infection, if there is a GIT problem, if there is any other underlying disease, you may miss it out because you have been biased to think only of what the chief complaint presented is about. And because of that, the American Physical Therapy Association, the US practice, they will not ask the patient about their chief complaint. And that is why I still left this slide on. I hope you can see it. On this slide, if you want to suspect a system, use the risk factors. And how do you get risk factors? You get it through asking about the biodata. So age, 60, cardiovascular, neurological, 35, 30, below, musculoskeletal. But 1 is not enough. You have to put together more. Now, this is where evaluation now begins to come. You don't go to the chief complaint. You now ask the patient about their family history. Has your father or mother or aunt or grandfather had stroke, diabetes, hypertension, list them, and then leave a space for open-ended question. Is there any other? So if they have had heart disease, you are counting that with the age, which is 60, under cardiovascular. If they have had stroke, with the age 60, you'll be thinking of neurological. Social history, they smoke, and they are sedentary. All these are building towards either cardiovascular or neurological. So what we're doing now is evaluation. But you can't have a complete evaluation and suspect a system until you complete this section under risk factors. Past medical history. When I was a child, I had pneumonia, and therefore I'm suspecting that this patient may have bronchitis or any other condition of pulmonary disease that comes in adulthood. Then the drug history. What drugs predispose someone to having any of those systems problem, neurological system, cardiovascular system, and what have you. So it's only when you finish this that you can now sit back and say, okay, from the information that I've gotten, what system of the body do I suspect? And then after that, you will now ask for the chief complaint. So when you ask for the chief complaint, the patient says, I have back pain. Then you now have musculoskeletal. So it's very possible earlier you would have suspected cardiovascular. Then at the chief complaint, you now suspect musculoskeletal. So in your history, these are the two systems that you want to focus on. What are the symptoms of cardiovascular diseases? What are the symptoms of neurological diseases? And then you now continue to ask questions, focusing more on these two. Of course, when we come to do systems review, we'll see that even those that you did not suspect, you are going to review them. But you don't review them in-depthly as much as you do for those that you have suspected in that first section, which is where you take the biodata, the family history, the social history, the past medical history, the drug history. So you do all these 5, then you ask the chief complaint. Then you now stop and say for the chief complaint, what system? You now combine that system with the systems you suspected in that first part for the risk factors, and that is what takes you into the history. History focuses more on those systems that you have suspected. Then under the history, you would have suspected a category of condition under each of the systems you suspected. So it is that category of condition that you now step down to your examination. What are the tests and observations that you do for that category? And then you continue to do those tests, you continue to do those tests until at the end of the day, you narrow down to one single diagnosis. So let me take us to the next slide that will explain more of this. So when the patient comes in, it's like a cone, inverted cone. This is where it narrows down that you have a diagnosis. Oh my goodness, it's still saying my voice is faint. What do I do now? Please, can you give me feedback? If it is still faint, I will need to change a device. It's possible it's from my system.
So you are audible.
Oh, it's audible now. Okay. Okay, thank you. Because I've moved the system close to me. But please, if just let me hear a second person. Is it still audible or either speak?
It's been very audible from my end. I've
Okay,
not
that's good.
had
Okay,
issue with hearing you, sir.
Okay, so that's good. Sorry, I hope I'm not shouting because I've raised my voice very high. Yes, so but when the patient comes in, without any bias, what is expected is that you are going to think of all conditions are possible. It's possible that the patient will have all conditions affecting the patient. So that is where you start, the base of the cone. You are thinking of everything. Of course, when you go through the process, these are the processes. I will explain them. And I've already explained them. I will just repeat it using this diagram. When you finish all the processes, at the end of the day, you're going to narrow down at this apex to have a diagnosis. And that diagnosis should be a physiotherapy diagnosis, which is a physical diagnosis. But what do you do first when the patient comes? Find out the risk factors. Biodata, family social history, past medical history, drug history. You sit down, you evaluate. After collecting all this, you now do evaluation. And we're going to discuss evaluation in the next few slides. But I think from what I've explained earlier, you know that when you collect the data, you are going to now look at it and say that what system has those risk factors, and therefore that is the system you are suspecting. So when you do the evaluation, it's going to give you one system, say cardiovascular system, or musculoskeletal system, or urinary system, or GIT. And there you have the individual. Okay, so maybe it's from another person. So it's after that evaluation, you have suspected the systems that may have a problem, because the risk factors seen are for those systems. You then ask about the chief complaint. When you ask about the chief complaint, that also is going to give you a suspicion of one particular system. It's possible the risk factors would have identified that system. The chief complaint is just adding to the suspicion. Or it's possible the chief complaint may give you completely different system than the one given to you in the earlier evaluation. So you now put down the systems. It is those systems, as I've said earlier, that you will go to history and begin to ask about their symptoms. So when you ask about the symptoms, you then do an evaluation. What that will give you is a category of condition under each of those systems selected here. And I'm going to explain to you, using neurological system, how you can narrow down to categories of conditions here. If you have a category that you suspect, for example, is it a vascular or is it degenerative conditions that you suspect? It's not one condition. There are many conditions under vascular. There are many conditions under degenerative. There are many conditions under inflammatory conditions. But at least you have narrowed down from all systems to a few systems to one category under each system. Then the next thing is to now go to your examination, your observations, your tests, your measures. Then you now do another evaluation. And at the end of the day, you must have a physical diagnosis. It's very possible that here there will be another step where I can't remember whether it was Kara, I think, or Zainab that mentioned that at some point they suspect and then they now send the patient for lab test or radiological investigation. So at that point that they suspect under that category of condition, maybe 2 or 3 conditions, they can now have an impression. Then they will now send for the lab test or radiological investigation. But by the time they complete all the process and they evaluate the findings, they should have a physical diagnosis. So this is what is called the clinical decision tree. And as I've said, our pattern in the past was to begin with biodata, chief complaint, history, past medical history, family social history, and then we do examination. But with the APTA template and the fact that we don't want to be biased, we don't want to miss a system that will be suspected if we already know the chief complaint, what the APTA does is to take the risk biodata, family social history, past medical history, drug history, they evaluate, and then they now ask the chief complaint, they now go to history, and then they go to examination or observations, tests, and measures. So let me stop here. That's why I told you that I wanted us to look at the 2 patterns, and then we agree on what we think will be the best for the Nigerian system, considering our transition to first contact practice. This may be new to some of us or many of us, but at least if we agree that we want to transit and we want to do it properly and we have justification that we want patients to come to us direct and we don't want to miss any underlying disease because of bias, then if we choose this, then this workshop is going to be based on this new template. But if for any reason we want to continue with our old factors, then that is what we are going to agree and do. But let's open the floor for discussions. Let's see what people think about this. Over to you.
Okay, thank you, sir. I will start by listing, why we talked about the method of assessment. I don't know, do I still need to go back to the comments on that?
Comment on yes, if you please, you mean the YouTube, right?
Yes, sir.
Please go, you can go back, because we want to carry everyone along, and those that are joining through YouTube, I think we need to get their comment.
Okay, sir.
It's
So
possible
here's
that after this we'll take a break. So let's just take all the comments and then we'll take a break. Then when we come back, we'll now start on the evaluation aspect. So just go ahead, look at it.
Okay, sir. So here we have, someone said biodata, chief complaints, history of chief complaints, primary.
Okay, so what we'll do, as you go through, if their comments are all aligning with the old pattern, I don't think we need to mention them, because we have all agreed that most of us use that pattern of biodata chief complaint. So unless if there is any comment different from what has been established, I think.
So someone has a question. Someone has something, said, sir, please, is it not better one gets the presenting complaints and history, as this will allow one ask the necessary questions on past medical history and family and social history?
Yes, so I think those questions came before my explanation about the new pattern. So let's have people make comments now. After listening to the old one and listening to this new version, what do people think? Unless if you think that post was made after I've finished the explanation.
Oh, there was no time input to it.
No time. So maybe let's look at the most recent.
I have more questions. Okay. Those I was reading out initially. Let me get back to them.
Okay, while you are looking at that, let Edna go ahead and speak.
Thank you, sir. So thank you for the wonderful presentation, sir. You have started something very good. It's important for us to move on with the global best practice. So at this stage, I really don't think that there's any question for us holding on to the past. That is the past. I think the only thing we should be discussing is how we can adopt this new templates in our clinics, at the academics also. Academic institutions are also instrumental in training the next generation of rehabilitation specialists. So it's for us to move on, sir, in line with everything that is being done elsewhere globally. And another thing is, I know that changing the assessment method is going to be very difficult at this stage for so many people, because of things like even the JAPA syndrome and all of that. Most clinics, if you go to most clinics, they are understaffed. But at the end of the day, what is good for the profession will remain good for the profession. Whether we are 1,000 PTs in Nigeria, 1,000 rehabilitation specialists in Nigeria, or we become 3 rehabilitation therapists in Nigeria, what is good for the profession, sir, should be what we all move with. And one of the ways that we can easily adopt this or adapt, as the case may be, is by also maybe changing how we carry out the initial assessment for patients. So I know that there are some clinics where they have 1 day or 2 days in the week where they do this assessment. It will be easier for those places, especially tertiary institutions, to make those changes, to make these necessary changes. Because for them, that whatever it will, no matter how many patients come within that day, what they do from the opening of that clinic, maybe by 7 to 4, is that they only assess for that day. While I know that smaller clinics may have difficulty, especially those that don't have enough manpower with doing this, because at the end of the day, patients come in at will. Sometimes they come in late, you want to go to the ward, or it's already time to close or something, and then they walk in. It may be difficult, but even at that, let us remember that this assessment process, because I think that's one thing that we keep forgetting. Assessment is an ongoing process. It's something that is supposed to be continuous as long as we continue to see patients. So if something is not done, if we are not able to finish, let's say 10 systems today, or let's say 3 systems, tomorrow is another day. At the next appointment, you can continue with some form of the assessment. If we start making this change, it will be easy for us before we make the overhaul. But for me, my submission, sir, is that we adopt this new template. Thank you so much.
Thank you so much, Edna. Thanks a lot. Wonderful. Okay, so let's hear from others. Because you know that when you do validation of things, you hear from people. If people accept it, it's much easier to implement. And if you don't hear from people, and maybe people have reservations and you have not explained to them why they should take it beyond that level of thought that they have, I think then you are going to have a problem with the implementation. So that's why usually I ask what people think. And it's very important for all. It was very great when we met in the Train the Trainers. It was unanimous. Not a single person said no. So I just want to see if there are people that have different opinions before we proceed. Yes, Mr. Olani.
Good afternoon, sir.
Good afternoon, sir.
Hello.
Hello, yes, we can hear you, sir.
Okay, thank you, able registrar, for this workshop and exposing us to the new trend. Not new trend in USA, but new trend in Nigeria. Changes, no matter what, will be met with some resistance. And then also when the change is for a positive one, there's no way a change is being introduced in a system, people will resist it naturally because everybody wants to be in a comfort zone. But this is become a global issue, and we are getting ready to start practice. We have been clamoring for first contact practice, physiotherapy first contact practice. So it's something that we must embrace. So we should not be discussing about whether we should remain in our old system pattern or whether we should embrace the new one. Definitely, we must embrace the new one. So definitely, this concept, the whole pattern, risk factor, biodata, all those things, evaluation, then chief complaint history, then you evaluate again, you observe, you make tests, you assess, all those things. I think before you make diagnosis, I think it's proper. With training and retraining, we should be able to key into it. And one thing I want to suggest is once a particular pattern of our new diagnosis is endorsed, we should find a way to make it in a paper form, those that are using folder, that assessment, you must follow a particular pattern uniformly all over the country. What is adopted, it is posted to every clinic in Nigeria. You download, you print as many copies as possible. That is what your assessment will follow, and a copy of it must be inside patient folder. Then those who have embraced electronic medical record, there should be a way to get a soft copy of it so that the management will find a way to input it in their system. In this our side here in Federal Teaching Hospital, we have been trying to do so, but generally we are using electronic medical record. The medical counterpart, they have been having a lot of issues because they are having different diagnoses. So they are now said the defender of that system, I think maybe not only us, so many other hospitals in Nigeria, like there's a directive that they must input ICD, International Classification of Disease, for the medical diagnosis. So the diagnosis must be uniform. That's what they are doing. We have been having seminar on it for over 2 months now. They have not been able to conclude, but they are working on it. Then we are discussing our own too. When they started this thing with physiotherapy, now ICF. So when we get all these things in soft copy, we are going to discuss with management. And the same thing with all hospitals that are electronic medical system, get soft copy, discuss with your management. So all these things will be put. So as you click, you want to track patient, that's what will display on the screen. And you must follow that pattern of assessment. It is not your own choice. It is the choice the MRTB and Nigerian Physiotherapy has adopted. You must follow. With time, we got used to it. America also started somewhere before they got to this perfection. After a year or so, we look at some little something we can modify. It can be modified again or updated. So that one is no problem. That's what I have to say for now, sir.
Okay. Thank you very much, sir. Thanks a lot for corroborating that suggestion by Edna. Thank you so much. Chidera, do we have any comment from the YouTube?
For now, there is none.
Okay.
Except we have to continue with the questions that I screenshot initially. All right, let me continue, sir.
We'll take few and then we'll take a break because it's already 1:15. Let's take few and then we'll take a break. When we come back, I will continue with it.
Okay, sir. Thank you, sir. All right. Someone said, after evaluation, I referred the patient back to the doctor for proper reduction. Please, am I right with my reasoning? Thanks.
Well, it depends what the evaluation result was. So we need to know what the evaluation result was. We are going to look at the issue of systems review, and we'll see what red flags and yellow flags are. If you see a red flag, it's an automatic referral. So when someone, for example, has, I mentioned it earlier, you say do you see any change in color in your blood and your urine? And you said, no, I see red, there's blood in the urine. That's an automatic referral. If, for example, someone loses consciousness, that's an automatic referral. There's no way someone will lose consciousness and it's not an organic pathology. So flags, and we are going to see those when we come back. There's a slide that I'm going to share, that I'm going to present on systems review. So when you see a red flag, it's a direct case for referral. But if you see a yellow flag is, for example, when you see all these ones that we mentioned under risk factors. Risk factors alone don't constitute a referral. It's a yellow flag. It's only when you have risk factors and some symptoms or signs that it becomes a red flag. But risk factors alone are not red flags. And there are some symptoms that you need to see 2 or 3 combined for it to become a red flag. Seeing only one symptom, you need to continue to monitor the patient until you see a red flag. So we are going to discuss red flag and yellow flag. What determines your referral to a physician is when you see a red flag. And in the slides, we'll see the difference between what constitutes a red flag and what constitutes a yellow flag. Thank you. Yes, before the next question, Mr. Olani, you are raising your hand again. Do you still want to speak? Okay, go ahead, Chidera.
Okay, thank you, sir. There are some comments here on the YouTube comment section.
Okay.
More like suggestions.
Yes, go ahead.
Says, will this new process be taught in universities? If they are taught the old SOPIA method and all, won't it be shock to them when they start internship?
Well, see, that's why we are having a national training. This national training is not just for clinicians, it's both for academics and clinicians, both for university staff and teaching hospital staff. So
they are the ones that will now take it back to their institutions. That's at this level that we are having trainings and advocacy. But from the board, we are going to get to a point where we'll give marching orders that if you don't do it in this way, we cannot license your students. Another thing is that we have a professional exam that we have now started. If you teach using the old ways and the time comes that we have already given marching orders that this is the current ways of doing things, then when your students come for the exam and they do the old ways, they don't pass the exam, they will still have to go back and learn the new ways before they now get their license. So now we are at the stage of validation. If we all agree to do this, then we will now go back to the board and we'll now come up with those regulations that we'll send out to all institutions, and then we'll encourage them to continue to do it in that new ways. The validation will not stop here. This is just the beginning of the validation process. If we agree now, we are still going to call for another stakeholders meeting that is just for discussions on that matter. Because this one is a training, we are just trying to see the opinions of people, but we are now going to call for a stakeholders meeting where we'll discuss the new template and then we'll approve or not approve, and then we'll move forward.
Okay, sir. Thank you, sir. Let me take these two comments all at once. It says a very good presentation and well recommendable. The newly adopted format should be in a template form and a regulatory body should be endorsed in ensuring its implementation. I have longed for this transition in the patient management assessment pattern. Please let's adopt this new pattern. I concur completely with Dr. Lani. And someone raised a concern. Honestly, this is new to me and still confusing or ambiguous.
Okay, someone said it's still confusing. Okay, so that's fine. Maybe when we return, we will review it before we get to the next slide. But thank you so much, the person that concur with the other speakers. What Mr. Olania has suggested is already in process. When we did the trainers, we extracted from the APTA template and we reviewed. We adapted because we removed some items, we added some items, and at the end of the day, we are going to have one that will be acceptable to all, and then we'll now put it with MRTB logo, and we call it physiotherapy client or patient assessment form or something like that. And then we'll now release it to all institutions, all facilities, all hospitals, and tell the CMDs that this is the new format approved by MRTB, because the act of the MRTB says it's the responsibility of the MRTB to determine the standards of knowledge and practice. And the standard of practice, this is a standard of practice. If it is approved by the board, then it is mandatory for all to use. But as I've said, we have to go through these stakeholder meetings to finalize it before we now put it in the document and send it to all the facilities. So thank you so much. Let's stop here. I will take a break. Let me ask how long the break should be. Should it be an hour or should it be 40 minutes? If it is 40 minutes, we'll come back by 2. If it is 1 hour, we'll come back by 2:20. And we get suggestions on how long the break should be. Okay, 2 p.m. is fine. So that's 40 minutes, okay? Oh, someone says an hour. Let's come back by 2. Okay, so I think we have 2 p.m., 2 p.m., 2 p.m. Okay, we have more of 2 p.m. So we are going to return by 2 p.m. Thank you so much, everyone. May God bless you.
Okay. Good afternoon, everyone. Thank you so much for joining us at the break. Please let me confirm I've changed my system. So just want to confirm if you can hear me now.
Yes, sir. Welcome back, sir. We can hear you
Okay,
from here.
thanks a lot. And can you see the slides? It's saying
Yes.
your screen sharing is paused, so I don't know whether
We
it's
can see
showing.
this.
Can you see the slide?
Yes, we can see your slide.
Okay, and is it moving?
No. Just first page,
So let me
first
stop
slide,
sharing.
assessment evaluation.
Okay, so stop sharing. I share. It's no more. So how about now? Is it moving?
Yes, it's moving.
All right, thank you so much. So we'll continue. This, okay, good. So let's continue. I think there was someone was asking about a repeat of concept. I can't remember what it was. Chidera, are you there? Can you remind me what it was that I said I was going to repeat?
Okay, sir. The person was asking, was talking about how confusing the
Okay,
new method is.
processes. Okay, the
Yes,
method.
sir. They
All
say,
right,
is this
so
new to me and still confusing or ambiguous?
okay, thank you. So let me just go back and say in the past, what we used to do is when we start, check the biodata. So just biodata, and then we now check the chief complaint. And the chief complaint takes us to the body system that we suspect. If someone says, I have weakness or abnormal sensation, think of neurological system. Someone says, I have back pain, think of musculoskeletal system. Someone says, I have difficulty breathing, we think of the pulmonary system. So it's like that. But what we are saying with this new system, so it's the same thing. After the chief complaint, we check the history. And then after taking the history, we then ask about the family social history, the past medical history, and other things. Then we now go to observation, tests, and measures, and then we make our diagnosis. So that's what we used to do. Only that maybe it's not as comprehensive as we're making it now, looking at evaluation at every point in time. I think that's the only difference. We do the evaluation, but I think it's more or less in our subconscious, and possibly it might not be comprehensive enough. But what we are saying here is that if you want to make a diagnosis on your own without waiting for someone to give you information or to give you the diagnosis, then you have to go through a very comprehensive process of waiting to do evaluation at every point in time. And the evaluation is what we are going to deal with in the next stages. How to do the evaluation, we have discussed the issue of clinical reasoning, analytical, non-analytical processes of remembering what data to collect. So we are now going to discuss how to interpret the data after it has been collected. So in this new process, what we are saying is that we start with biodata, family social history, past medical history, and drug history. Then we evaluate. How do we do the evaluation? Look at it in the next slides. But the evaluation will lead us to the suspicion that one or two or more systems of the body may be affected. But this is just a yellow flag. Don't suspect a system and we refer. No, have to wait and finish the whole process before we now see if there is a red flag. So then we now ask the chief complaint. So in this new system, the difference with the old one is that in the old one, you check biodata, you check chief complaint. But in this new system, biodata, you then next go to family social history, or family history and then social history, then past medical history, drug history, do the evaluation, and then you now ask about the chief complaint. Why? So that you will not be biased into forgetting all other systems and focusing on the system of the chief complaint. So that's just the difference between the old version and the new version. Another addition to the new version is that issue of evaluation. After this stage, then when you do the history, you evaluate. When you do the observation, tests, and measures, you evaluate. And what do you rule in as you go through the process? Initially, you are thinking of all conditions. But by doing the biodata, family social history, past medical history, drug history,
when you evaluate, you narrow down to one system out of the many, either one system or two or more, depending on what the result of the assessment is evaluated, how it is evaluated. Then after that, you do the history. So when you take the history, instead of a system, you now narrow down to one category under the system. This also, we are going to look at how to do that next slides. Then when you get one category of condition under the system suspected at this level, the next thing is to do observations, tests, and measures, and that will lead you into narrowing down from a category of condition to only one condition, which is going to be physical diagnosis. So I hope that this sounds better, but if it's not, let's go through any part, then be able to see, understand more evaluation. So the risk factors. Remember, we are not asking for chief complaint. So at this point, we're asking about the age, the gender, and a number of other things under risk factors, which are the biodata, the past medical history, the family social history, the group history. So after you have completed taking that data, you now sit down. You say, okay, what have I seen? I've not added age and gender. I mean, we all know that under cardiovascular, the age, the higher the age, the more the risk of cardiovascular disease. So there's something with gender. Some researchers have shown female are more prone to having cardiovascular diseases than men, but then might be maybe subcategories where men may be higher in some conditions and not all the cardiovascular system. So I've left those out. So under past medical history, if the patient reports having high blood pressure, so this is past medical history. So it's up to you to be able to categorize this under those categories of biodata, past medical history, family social history, and group history. So high cholesterol, this is going to come under past medical history too. So the patient is going to say, I've been diagnosed with hypercholesterolemia or something like that. So they have high cholesterol, or it's going to be one of the tests that the patient is going to give to you. Say, I've already done some tests and look at it, and then in the test you see they have high cholesterol levels. Then obesity. Obesity is something that will come either reporting that they were diagnosed with obesity. They'll say diagnosed, they have been informed to have obesity, or be when you get the information about the weight and the height, be able to know what the obesity is. Sedentary lifestyle is under social history. So you are asking how do you physical activity, say yes, okay. Is it moderate, intensity, high intensity, low intensity? They don't know, you are now explaining to them. Just walk slowly, do you walk fast, do you run? What do you do? Or if it is walk, what type of walk, how much of energy do you expend? Well, not energy expended, but we know the questions to ask to be able to know if they have sedentary lifestyle or they are physically active. Family history. So now this is family history. Family history of heart disease, and then chronic kidney disease. This is past medical history. Chronic kidney disease, and then chronic stress. It's not all the risk factors of cardiovascular system that I have here. This is just to serve as an example. So after you finish that first part, you have taken the biodata, past medical history, family social history, drug history. Now stop and you say, okay, this patient has reported high blood pressure, high cholesterol, obesity, sedentary lifestyle, mom or dad had heart disease, the patient had chronic kidney disease or chronic stress in their past medical history. You say, oh, all this put together, these are the risk factors for cardiovascular system. And therefore, I suspect this patient is at risk of having cardiovascular system. So at this point, it doesn't indicate that they have cardiovascular system problem. It is just saying that you suspect that they may have, and therefore this is a yellow flag. So this is a yellow flag, but at least you have suspected a system. Even if the patient does not have any symptom, at least you know this patient needs to be advised to reduce cholesterol level, reduce their weight, you ask them, are you taking medication for your BP? Yes. Be very, very consistent. Because if not, these signs that I'm seeing are signs of cardiovascular system disease. You may have cardiovascular disease in the future if you take care of it. Please, sedentary lifestyle, you need to start doing exercise. And you advise them. So there is no symptom. Prevention, very important. You now advise them on how to prevent all these things. But if after the process, you find out that, smoking also will come under cardiovascular. As I've told you, this is now metacognition that I'm doing. That I've asked the questions, I did not, I've put down things, I've not put down other things that are important, like smoking. But under pulmonary, because smoking is very, very key under pulmonary system, you see I've included it there. So address, sometimes we just ask about the address of patients and we just, for record purpose. No, you ask them, what's your address? Isn't that, for example, I know in Kano, when you say Sharata or Bombay, or where is it again? So there are some states where the name of the area where you live, there are going to be pollutants. Say biomass fuels. They live close to industries that will emit biomass fuels, or places where there will be such oxidants and chemicals and what have you. Then occupational exposures, your job. So under biodata, what is your job? And they say what their job is. You can be able to know if, sorry, just a second, let me see if I can. Okay. So what is your job? Your job is not just for the purpose of data, keeping data, just to record. No, it helps you with now. Can you see what we are doing now? It's reasoning, we are thinking, and we are using the thought to make a decision. And that thought that we are using here is called diagnostic reasoning. Diagnostic reasoning, because the process is leading us towards narrowing down from all conditions to at least one or two systems of the body. So where do you live? Air pollution. What is your job? Occupational exposures. So if they say the job, what does it entail? Are there emissions of this or that? Oh, yes. Oh, then you will be at risk of having pulmonary diseases. Then genetics. My father has had asthma. My mother has had asthma. And therefore, I can be prone to having asthma. Past history of pulmonary condition. So as I've said, you have had pneumonia and have the condition. Or lung. So this is something that on the past medical history that diagnosed with lung. So put together, what does it mean? What it means is that I should suspect the pulmonary system. This is evaluation. Do you smoke? It's an assessment. Where do you live? It's an assessment. Where do you work? It's an assessment. Does your father have pulmonary disease? Has your father had, or does your father have pulmonary disease? But at the end of the day, you sit down, you look at the whole picture and you say, all these things put together, they mean I should suspect pulmonary system. Neurological system, genetics. My father has had stroke. My father has had Parkinson's disease. Lifestyle. So all those things that are under lifestyle, sedentary lifestyle, smoking, alcohol intake. So all of them, lifestyle, are risk factors for the neurological system. So that's what we're talking about. Just because someone smokes, take alcohol, it's not enough to suspect a system. Because it could be neurological, it could be cardiovascular, it could be, you can see that they appear in both. But what is it in neurological that is not? Okay, let's go back there. Let's see. This is what evaluation is all about. You see smoking here. I didn't mention smoking here, but it's also here. You see air pollution, biomass fuels. But is it a risk factor for cardiovascular? Not likely. Under pulmonary, it's there. Genetics. If you have pneumonia as a child, will it lead you to having cardiovascular system disease? No, it will be pulmonary. So there are some that will cut across board, but there are some that will only apply to one. And therefore, putting it together, the common ones, but then with additional ones that are only applicable to one one system is what gives you what system you are suspecting. This is what evaluation is all about. It's about reasoning, it's about thinking, but can you think without information? If you don't collect this data, you can't think. And that is why the analytical process is important. And if you continue to use it and you continue to use metacognition, continue to update. Because if not, you'll have only 3. And 3 risk factors will not be able to give you an indication of what system. Smoking, sedentary lifestyle, alcohol intake. You have just those 3. It could be pulmonary, it could be cardiovascular, it could be neurological, because it applies to all of them. So you need more of those assessments to be done, so that at the end of the day, okay, we have all these 3. It could mean 3 systems. But now that I have genetics for pulmonary, I have past history of pulmonary condition, I have poor lung growth, put together with these 3 that are common across board, I will now rule out cardiovascular and neurological. I will now go with them. This is clinical reasoning, and this is evaluation. So with the urinary system, let's not forget, during our first part, biodata, past medical history, family social history, drug history, can suspect even conditions that are not within the scope of our practice. For example, if someone has an organic pathology in the urinary system, what are those risk factors? Gender. Female, they are more at risk of having upper tract infection, urinary tract infection. For males, they are at risk of having prostate. Then diet, high sodium. So this under social history, high sodium. Do they take high intake of sodium or sugar? Lifestyle. So those lifestyles that we have talked about across board, can you see they are appearing in almost all the systems? Alcohol, smoking, sedentary lifestyle. But by the time you have past medical history, that the patient had been admitted recently, they have catheter, they were catheter, they had gout or diabetes, or if female had pregnancy recently, all this put together gives an indication of a urinary system suspicion. Environmental exposures, pesticides, agricultural staff in the research center, pesticide, industrial chemicals. So they work in the industry, use chemicals a lot. That, past medical history of diabetes, catheter use, gout, or pregnancy. Lifestyle, diet high in sodium, and it's a female. TI, if it's for male, you suspect prostate. So this is evaluation. What helps you? The information. How do you upgrade the information? If you can only remember 2 or 3, go back to the books, check when next another patient comes, you add more. Because with little information, you are less likely to be able to select one system out of the many systems that are available. So that is under the biodata, past medical history, family social history, drug history. You do all this evaluation at that point. So all these ones that we have mentioned, you do that. You select a system. After that, you now ask the chief complaint. So you must have, say, suspected urinary system and neurological system. So that's what you suspect that the patient may have or may be prone to having. Then you ask the chief complaint. And they say, I have low back pain, and you now add musculoskeletal system. Meaning there are 3 systems that are suspecting that point in time. Is diabetes under lifestyle? Is under past medical history. It's under past lifestyle usually comes with the issue of smoking, alcohol intake with sedentary lifestyle. Diabetes will come under past medical history. I need more explanation about the analytical and meta-analysis. Metacognition is analytical, non-analytical, and metacognition. Analytical, you read a book. These things that we're talking about, I got them from the internet. I just Googled and say risk factors of neurological system. So what I did was an analytical process. And I got genetics, lifestyle, infection. If you go and Google, you'll get all this. Diabetes is also a risk factor of neurological system. So meaning you are doing metacognition. You can go and add it there. And that's what metacognition is all about. I'm not hearing anything. Is it only Selma that cannot hear, or can other people give feedback?
We can hear you, sir.
We can hear you, sir.
Okay, so Salma, please look at your speaker or gadget, your device. Yes, so the analytical is the one that you read, you Google. This lecture that you are listening to is analytical process. It's an analytical cognitive process. Because anything you capture from this, when you are seeing your patient, so we are going to do the hands-on. When you go for the hands-on and the facilitator say, do you remember what the presenter mentioned during the virtual? I say, yes, we remember under neurological, say genetics, lifestyle, infections, head injuries. Oh, that's analytical. But by the time you apply it on one patient, another patient comes, you remember this lecture. Another patient comes, you remember the lecture. After some series of patients seen, you are not going to be remembering lecture or books anymore. You are going to be remembering the last thing you did to the last patient. So that is non-analytical. It is now experiential. It's not coming from books or lectures that you remember. You are remembering the actual experience of applying the data. So now, this once somehow, people I think just was saying diabetes is also under neurological, but you can see I didn't add it here. So for me now, Abimbola has helped me with metacognition. When next I'm asking patients and I want to do evaluation for neurological, I'm going to also consider diabetes. So I say, okay, you have diabetes, okay. All this put together, infection with the genetics, they all predispose you to having a neurological system condition. And remember, it's not necessary that all this must be there for neurological system are enough for you to be able to say, I still suspect neurological system. So even though there is no high BP, there is no diabetes, but there are toxins and pollution, there is head injury, there is infection, genetics, lifestyle, you say, oh, these are enough. So what makes it enough? I don't know. I will leave that to you to begin now to search and see when is it enough to say that I suspect the neurological system or the system. So I hope that's clear now. So what we have done is for risk factors. Under what section of the Clarkin, biodata, past medical history, family social history, work history. Now stop. You do the evaluation, and that's what we just did. And then you select what system you suspect. Then you ask chief complaint, and then from the chief complaint, you add another system. Then you now go to history. So under history, you ask the questions. Remember I told you, you need to know what are the symptoms of diseases or injuries under that system that you have suspected. So we have suspected neurological system. We now pick neurological systems. What are the symptoms of neurological system? Of course, the chief complaint has said there's weakness, my upper limb or in my lower limb, upper limb and lower limb, my two lower limbs. Now, we begin to now ask questions about that symptom and other symptoms. You then ask these questions that will help you with the evaluation. What you want to do now is from neurological system, you want to narrow down to a category under the neurological system. Is it vascular conditions? Is it inflammatory conditions? So vascular conditions such as stroke. Inflammatory conditions such as when you have this accumulation of fluid between the brain, pia mater, right? So accumulate there as a result of injury, the fluid accumulate in between. That's an inflammatory condition. There are other inflammatory conditions. Example, under this issue of subacute, you can have things like barrage. Discuss that later. Degenerative conditions such as Parkinson's disease, dementia, and demyelinating conditions, and things like that. So how do you categorize and say the condition of this patient is vascular, is inflammatory, is degenerative? As a physiotherapist, you don't need to narrow down to the organic pathology, the condition of the organic pathology. Under organic pathology, you stop here, the category, that's it. And I will show you examples of physical diagnosis. You don't have anything that says secondary to stroke, secondary to cerebral palsy. What you see is secondary to non-progressive conditions, which is vascular. is non-progressive, it gets better. Secondary to progressive conditions, which is the degenerative. Because degenerative, it continues to progress. So it's degenerative conditions are progressive conditions. Or fluctuating ones, which is the inflammatory conditions. So what questions do you ask under history to categorize under an apology to all those that are not in neuro? I'm in neuro, I'm more comfortable giving an example here. But auto, pulmonary can all come up with the evaluation for how to categorize conditions under your specialty. Pardon me, in bias and picking neuro. So one of the questions that you ask after asking about the symptoms, those symptoms that you have established are present. When did they appear? So the patient maybe says 3 months ago, or they give a date. So from that time, over what period did you experience the highest level of the symptoms? So for example, they say weakness. The worst weakness that you have had so far, how long did it take to reach that worst that you have had so far? So maybe the patient had complete paralysis. I couldn't move at all. How long did it take you not to move at all? Say within minutes or hours. So a presentation like this is called acute. And acute presentation usually is a characteristic of a vascular condition. So like stroke, just burst, or it completely blocks, and within minutes or hours, you have. If it is partial paralysis, maybe you have gotten better. But at the point that you had the highest paralysis, weakness, how long did it take from the time the weakness began until it reached maximum? Minutes or hours is vascular, usually vascular implementation. You can have, that's what clinical reasoning is all about. Maybe a case where the blockage is there, it moves, it blocks, it moves, maybe it takes much longer than hours. But typical presentation of a vascular condition, the symptom build up to the highest level for hours. If the answer to that question is that it takes days or weeks, it's inflammatory. There's this story of Natasha Richardson, wife of Liam Neeson, right? Actor. She went for skiing, she fell, and people said, you should go to the hospital. She said, I'm fine. She stood up and she was okay. Only that she didn't continue, she went back to her hotel. But over a few days, she now began to feel dizzy and she began to have headache, and they took her to the hospital and she died. And when they did the diagnosis, later realized that there was a leak, but because it was leaking little by little, it was accumulating. It took days or weeks before it got to the point that it compressed the brain, and that's when symptoms began to appear. So subacute will take days or weeks before you have the maximum symptoms. Usually it's inflammatory. And for people that have diagnosed Guillain-Barré syndrome, I give an example with that. We say between 4 to 21 days, that's when the maximum symptoms will appear. So these are subacute presentations. But as I've said, I just gave an example with the condition because it's a common thing that we see. But as a physiotherapist, you don't need to go through the process of diagnosing a medical condition. All you need to do is just to suspect organic pathology. You're far to diagnose. When the answer is months or years, so it started 6 months ago, and it took 3 months before I had the maximum symptoms, then that's more of degenerative. So usually, you don't just ask this for evaluation. You have collected data, keep it. Next, ask about the pattern of progression. From the time you had it until now, has it been getting better, worse, or has it been fluctuating? If the patient says it has been getting better, it's more of a vascular condition. So you now put the two together. The onset is acute, the pattern is improving, this is more likely vascular. Fluctuating is more of inflammatory. As I've said earlier, the accumulation of the fluid, if you change position, the symptom will reduce. When you change to another position, the accumulation compresses the brain, you feel the symptoms more. And therefore, if it's inflammatory, it's fluctuating. So if it is subacute and fluctuating, think of inflammatory conditions. And if it is worsening, and the patient said the build-up was over months, chronic and worsening go together, and you have a suspicion of chronic condition, a degenerative. So this might be too simplistic, because apart from these three, there are other categories, and you go through evaluation in a more complex way than what I've just presented. But this is just to show an example of how you can do an evaluation. Collect the data, make sense of it through clinical reasoning. And you can see analytical process coming in. If not because I have this theoretical information, minutes, hours, days, weeks, months, years, if I go to ask the patient the question, I won't get the data that would be required for even the evaluation. Improving, fluctuating, worsening. In clinical reasoning, these are called semantic qualifiers. And understanding them, they say shows expertise. And when you go to the word, you are saying, well, it's an acute case that is improving. It's a chronic case that is worsening. So it's a subacute case that is, it shows that, wow, this guy understands this field. This is talking from technical point of view. And at the end, is making a decision that is indicating something has been narrowed down from something bigger to something smaller. We are getting somewhere with identification, what disease, what injury, what condition the patient has. So I'm going to rush through this, all the other sections because of time. See, it's already 2:30 and there's a lot to go through. As I've said, these are all part of courses that we are going to take next year. And the reason why I'm taking time, I took time on the evaluation, because I said it's one of the key things that we are going to focus on this workshop. Now, remember the next thing that I talked about is the issue of physical diagnosis. I would have started with, or maybe I should go back on the systems review. Then after this, let's just focus on the physical diagnosis, because the systems review is about screening for organic pathology for the purpose of referral. So let's start with the physical diagnosis. How do we make physical diagnosis? Based on all this evaluation, we are building a case. We have looked at biodata, past medical history, family social history, drug history, and we suspected a system. We asked the chief complaint. We suspected a system. Now, these systems, we are picking each one of them. We have picked neurological system. We now asked questions. We did evaluation, and we were able to narrow down to a category of conditions, say vascular condition. So that vascular condition, we are now going to the next stage, which is examination or observations and tests. So what are the tests that we do for a vascular condition? You have a vascular condition, there's possibility that you have weakness, you have sensory maladies, you have cognitive impairment, you have balance problems. So you now begin to do tests that will help you to identify if each of these domains that I've mentioned is present or not. That is what would determine your physical diagnosis. But generally, I've explained this slide. We know diagnosis, I will not explain that. But the difference between medical diagnosis and physical diagnosis, I've also explained this when we were talking about human movement system. If you are establishing organic pathology, it is medical diagnosis. If you are establishing movement dysfunction or movement impairment, then we are dealing with physical diagnosis. But therefore, our terminologies for the physical diagnosis should not be organic pathology terminologies. It should be movement dysfunction terminologies. Of course, we know the differential diagnosis. We are ruling in and out to pick one and all others. That's differential diagnosis. So the organic pathology, I've explained this. Observable and measurable disease presence, inflammation, tissue damage, I think I've explained this. Usually validate them using biomarkers. Go for a test and you see the type of infection that is in there. You say, oh, this is an organic pathology because it's bacteria or it's viral or it's whatever. Movement system diagnostic classification. All diagnostic areas of physiotherapy can be described as movement system dysfunction. Every diagnosis that you have must be movement system related. Diagnostic classification is a foundational underpinning of providing care. As you are a movement specialist, the diagnostic classification should be a movement related, but also it should determine what interventions you give. From your diagnosis alone, you're able to know what interventions would be relevant, and we'll see that later. So diagnosis is pattern recognition. Someone mentioned pattern recognition earlier, discussing the issue of clinical reasoning, non-analytical. So it categorizes conditions that ideally direct treatment. Movement system diagnostic classification are specific to direct treatment. So what is important in movement system diagnostic classification? Recognize movement-related terms. Very important. The terms you use must not be organic pathology related, they should be movement related. Include, if deemed necessary, the name of the pathology. Now, that is where we are now thinking of non-degenerative or degenerative conditions. We are not seeing the condition, stroke, Parkinson's disease. No, you don't mention them in a physical diagnosis, but the pathology can be mentioned. Be as succinct and direct. Strive for movement system diagnosis across life populations, lifespan and span. Movement-related terms, very important. Now, let's look at this. Most at times we use this terminology: shoulder instability, frozen shoulder, adhesive capsulitis, shoulder impingement, rotator cuff disease. If you use this in your diagnosis, you are doing a medical diagnosis, because each and every one of these is related to pathoanatomy. Look at them. They are related to pathoanatomy, not kinesiology. Your terminologies should be kinesiology, either pathokinesiology or kinesiopathology. That is why earlier it says you can mention the pathology, not the condition, not the condition, the pathology. So mention the movement impairment terminology and relate it to the pathology. Kinesiopathology, movement term, pathology. Pathokinesiology, pathology, movement term. Now, these conditions that are organic pathology in bullet 1 can be easily adapted to a movement system framework by reframing the diagnosis broadly as, so if you are having shoulder instability, your own terminology should be hypermobility or stability deficit. Shoulder, frozen shoulder or adhesive capsulitis may be hypermobility or mobility deficit. Shoulder impingement or rotator cuff disease, aberrant motion or movement coordination deficit. These are your terminologies. These are the things that we should see in your physical diagnosis, because that is what you are going to treat. You are not going to treat a frozen shoulder. You are going to treat the hyper or hypomobility associated with the frozen shoulder or the adhesive capsulitis. Your treatment is not treating the capsulitis, but it is treating the movement consequences of the capsulitis. So if you have adhesive capsulitis, if it is just an organic pathology that sets, usually it is through movement, isn't it? Repetitive movement. That would now be kinesiopathology. But if it is an infection that leads into adhesive capsulitis, then it leads into hypo or hypermobility, most likely hypomobility, then it's now going to be kinesiopathology. So even though these are not highly specific, but they are better than using organic pathology, things that you are not going to treat. So the advanced specificity beyond regional pain categorization, such as calling it subacromial pain syndrome or shoulder pain of. So hypermobility, hypomobility, movement coordination deficit. So this is the shoulder. Hypermobility, instability, stability deficit. Hypomobility when you have adhesive capsulitis, arthritis of the shoulder, post-fracture, called mobility deficit. When you have aberrant motion, it goes with rotator cuff, labral tears, impingement, nerve injuries, have pain. Yes, I'll come back to those questions on the chat forum.
Don't go and press anything there.
Selecting, yes, sorry, can we mute ourselves? Okay. Now, selecting a movement-related terminology in your diagnosis, your physical diagnosis, helps you to be able to choose a treatment that matches it at the end of the day. So if your diagnosis is about hypermobility, what you need to do is to improve functional stability. If it is hypomobility, you are improving functional mobility. If it is aberrant motion, you are improving functional movement coordination or balance or mobility and stability. It is in this section that usually musculoskeletal and neuro become friends. Because in neuro, you are improving functional movement coordination or balance or mobility. And in the same way, you can have a musculoskeletal problem where you need to improve movement coordination or balance or mobility stability. So your terminology determines what your goal of treatment is, and your goal of treatment will determine what intervention you apply. So going forward as physiotherapists, don't just assess patients and give them one package, one package suit all. What we see, what terminology we pick determines the goal. The goal will determine the intervention. And we'll see more of that in the next few slides. So force production deficit, we are dealing with strengthening power, coordination, control deficit, endurance deficit, soft tissue. So what do you do for each? Force production deficit, target low repetition, high load exercises. Coordination, target motor control retraining. Doesn't matter whether it is in neuro or orthopedics. You have coordination or control deficit, target motor control retraining. Because you can have coordination problem as a result of the brain having a problem such as in the cerebellum or whatever. But you can also have control deficit if you have muscles that should be co-activators and one is weak, one is strong. Therefore, you have control problem. So you need to have control training. It could be musculoskeletal. So endurance deficit, you target high repetition, low resistance training. Soft tissue, soft tissue flexibility deficit, target stretching and mobilization. So your diagnosis or the terminology you use determine what intervention give. This is in a paper called Lidwig et al. 2022. I think I have the reference. If the reference is not there, I will check and I will release it onto the platforms so that we can be able to access the paper and study it. Now, this is another one that even brings it down. Now, functional anatomy. This is where we'll appreciate understanding of functional anatomy. Classification subgroup. It's about scapulothoracic movement classification. How often do we go down to the level, not just the shoulder complex, but we go down to scapulothoracic movement classification? Primary movement impairment. The movement system contributors. If you have insufficient scapular upward rotation, so all these four will be different classifications under scapulothoracic movement classification. Say insufficient scapular upward rotation, it could be insufficient lower serratus anterior force or activation. Insufficient lower trapezius force or activation. So this is where you now go back, assess the serratus anterior, assess the lower trapezius, and you'll be able to see which of those two contributed to insufficient scapular upward rotation. You need to also understand how do you assess to know if the scapular upward rotation is not sufficient. Then you now say that it's a scapulothoracic movement classification that is as a result of insufficient scapular upward rotation due to lower serratus anterior or activation insufficiency. So that's how insufficient scapular posterior tilt, posterior capsule. Now, we are looking at muscles, scapular upward rotation. And now we are looking at the soft tissues of the joint, capsule tightness, and see also muscles, pectoralis minor, insufficient lower or middle trapezius force. This is lower or middle trapezius, while this one is lower serratus anterior. This is lower trapezius. This is lower or middle trapezius. Each of them will lead into a particular classification, primary movement, and you can have excessive clavicular elevation due to excess upper trapezius. This lower or middle. And you see now, you need to even start thinking, how do you assess activation of the upper trapezius, the middle and the lower trapezius? Because each of them is giving rise to a different classification. As I'm explaining this to you, I'm not a musculoskeletal. I'm just explaining. One of you will pick it up and go and do it. I can't practice it, but to me, it's interesting because I can see how I can be able to go to a word round and speak, and I would lose all the those that, because you talk about stroke, talk about Parkinson's disease. Tell me what is it that you are going to check a medical doctor. Now, this one knows something. But this is your field. So forget what is not within the scope of it. Focus on what is within the scope of it. When you speak, an authority speaks. And it's not just about impressing people. Sorry that I have to that as the first issue that I think is important. What is important is that if the patient has excess upper trapezius activation and the treatment you give does not come down to that muscle activation, whatever you do to the patient, give them short diatemy, just give them general exercises, your hand up and down, resist, and the patient will not get better. But the moment you identify down to the level of upper trapezius or lower trapezius or mid trapezius, come and see how the next day patient will come and say, pain has gone. What did you do? For 10 years, I've been having this problem. That exercise that you gave, no one gave me that exercise, not knowing that that exercise targeted upper trapezius activation. Patient gets better. So these are important things. We need to now begin to focus on this diagnosis, the physical diagnosis, using the classification circle. There's another one. But this one, we are looking at a process of evaluation that either gives you a physical diagnosis or suspects a medical diagnosis, and you are using information and you are making a case for what should be ruled in. So this is about TMG. I have the TMG pathology. This is mouth opening. So when the mouth opening, you measure the mouth opening, and it is more than 40 millimeter. So mouth opening, 40 millimeter. So if it is yes, we are looking at mobility deficit. If it is no, we are looking at coordination deficit. If it is a mobility deficit, we are now looking at either joint mobility deficit or muscle mobility deficit. If it is joint mobility deficit, it's about the noise that it makes. That, sorry, it's not noise, sound. Is there any click? And whether there is a pain. So if you have only pain, you are suspecting TMJ arthralgia. But if it is only the sound, we are suspecting DDWR. I forgot to check what that stands for, but it has to do with the temporomandibular joint pathologies. Then when you have joint pain and crepitus, both of them, then you are thinking more TMJ osteoarthritis. So can you see evaluation? Collect the data, and you now use this to now make sense of it. Some you will refer, because for example, you have an osteoarthritis, it's an organic pathology you are referring, but then you are keeping the patient because of the joint mobility deficit that they have. This is a more to keep. And I'm not going to go into details about this because this is not the purpose of this workshop, just to show you need to start having physical diagnosis on the diagnosis that we want to treat. So remember, I talked about the issue of not just assessing symptoms, but assessing sustained alignment and body movement. This is a site, and I think I will have the address of the site. Maybe next. It's called Clean, which was for pediatrics. So this is the address, haba/assessment.org, assessment.org. So what it has, initially you will have the information, name, location, date, go to the head, go assessment, the sketch. And after the sketch, you'll have a summary. And then it gives you recommendations. Where is the problem and the problem, not the symptom. We are not talking of symptom now. We are talking of the source of the movement patient, especially if it is kinesio. So can you see the alignments? What you are going to do is it in extension? So the head of the patient, some patients will come, a head is extended. So under extension, you select extension 5 degrees to 20, can't have more than 20 degrees of extension, and therefore, but under flexion, you're going to have 1, 2, 3 options. Whatever alignment of head is, flexion or extension, select. So at the end of the day, you do for all the joints, and then after that, you have a summary. So the summary will give you areas where there is misalignment or malalignment or whatever, and then it will now give you a sketch. So if there is a malalignment here, it's possible you will see this comes down while this one goes up. At the hip, see the hip, one goes up, down, and see it from the side to see, so, and have different sketches. Then recommendations. Tell you if it is in the head, what postural problems are possible. Required interventions. What interventions do you give? For the trunk, what postural problems and what interventions should you give? Very simple to use. Apology, I don't know what happened. I was kicked out. Sorry, so let me just ask if you can hear me and see the slides.
We can hear you clearly now. We can see the slide.
Okay, wonderful. Thank you so much. So I'm going to rush
Yes, we
because
can hear you
I
and
think
see the slide.
so that before I get kicked out again, I would have covered some parts. As I've said, all these are areas that we can't just have in details in this workshop, but as I told you, they are all part of the workshops of 2026. Each of them will be taken separate, and then it will be a day or week workshop that we've done each of them. So this is another, that one is for sustained alignment. This one is for functional movement. And this is the website, rehabeducation.com, functional movement assessment. So it's going to give you a label, functional, non-painful, functional, painful, functional. functional description. Can we mute ourselves, please? Russia. Okay, I'm not admin because I use another system. So please, the admin can mute. So this is what you are going to see. Looking at different movements: active cervical flexion, active cervical extension. Going to now score according to what I showed you earlier. So this one's limited, restricted, or limited, unrestricted, and what have you. So it's going to use that. Each movement will enter a score. Then at the end of the day, you are going to have scoring that gives you indication of what movement impairment the patient has. So this is something also that we are going to deal with a workshop of its own. It's called the SFMA. So that's for these slides. I'm going to stop here and ask for questions if there are. And then the next thing is to show the APTA template, or maybe we'll look at systems review. Just a few minutes, and then after systems review, I will show you the APTA template and possibly the adapted one that we got from the trainers. Then after that, we'll open the floor for discussions generally. I would want a longer period for that than the presentation. But let me just ask if there is any question with regards to what we have just done after that. Yes, Suleiman Amin.
Good afternoon, sir.
Good afternoon.
Yeah, well done, sir. Please, my question is with respect to this KABA assessment. How related is it with the APTA template?
Okay, the APTA template is just a template that indicates the process and the sequence of information collected. Now, thank you for this question because there's something that I wanted to mention earlier. Now, this is just a pattern. I'm going to the biodata, past medical history, family social history, work history, before I now get down to the chief complaint, and then I will now take the history, do system review, I will do examination, and then I will get my diagnosis and the plan treatment. So that's just a template that gives you the pattern and guide data collection. But now this KABA, if you go under examination, it's one of the things that you are going to do. All these things will now the things that you want to, it's part of the examination. It's something that you have to enter, have a score. So there are so many others that are not in the template that it's up to you. When you suspect a system, you go to history, you suspect a category. Under that category, what are the signs? Now, what are the outcome measures that you should use to be able to see if those signs are there? So you don't have to be limited by what is written in the template. Template is just a guide. Another thing very important. Last year, we had a workshop. In fact, it was a workshop that myself, I learned a lot from about that WHO PIR, packages of interventions for rehabilitation. They said, have the body into quadrants. And when you do your assessment, assess impairment, disability, and handicap. And using quadrants. Some people will find it very easy to use quadrants. Some will not find it easy to use quadrants. Whatever you want to use, what is most important is that you must collect all data. But doing it in a particular pattern, like using the quadrants, will help you to be able to simplify it so that you ensure that you collect all the data. So it all depends on what is convenient for you. What the APTA template does is just to give you that pattern, what you do and what is next until you get to diagnosis. But any other thing depends on your clinical reasoning and the presentation of the patient, whether they have this system suspected, whether they have this category under that particular system, what are the things that I should do when I get to that stage? So that's the situation. Ibrahim Abubakar Achid.
Well done, Prof. My question is about the impression, physical diagnosis, using of these medical terms. I say, are these only applicable to impression, physical diagnosis, or sometimes how we were trained, we use the physical diagnosis plus the medical diagnosis, like in a stroke, impression, like impaired functional performance of either right or left side of the upper or lower limb, or sometimes side of the body associated with weakness or pain or something like this. Secondary to non-progressive neuromusculoskeletal central nervous system. So, but in a patient with stroke. So, how does that is this also proper or improper? We need not to mention anything like stroke day or CVA, CVD.
Well, I think when we get to the template, I will show you the different examples of physical diagnosis. And I'm going to explain to you the terminologies, and you are not going to see stroke, CP, Parkinson, you will not see them there, because it's not necessary for you to go down to a specific medical diagnosis. All you need to do is just to indicate the pathology. And I will tell you why that's not. But if it is a vascular condition, a non-progressive condition, the treatment that you give, the exercises that you give, strengthening, usually can be similar. What matters is the movement impairment, not really the specific pathology. So if you have the general pathology, it's surface, because may not be different across the conditions. But clinical reasoning may tell you that there will be difference. But you are not the one that will go ahead and make the stroke diagnosis. You are going to refer. And when the physician makes the diagnosis, or the neurologist, then you now use that diagnosis to now do whatever is specific to only that condition. So that's it. But wait, let's get to the point where we'll discuss the physical diagnosis examples, and then I will show you what has been established as physical diagnosis. Chidera, can you let us know if we have any comments from, yes, okay, Abimbola, go ahead while Chidera is checking for YouTube.
Good afternoon, sir. Well done. So, while we are still on physical diagnosis, I know I quite understand the concept here, but now most of us, right from time, it has always been medical diagnosis. Most times it's medical diagnosis. So, are we trying to say during our process of documentation, apart from writing physical diagnosis, is medical diagnosis not also relevant to physiotherapists during our process of assessment and documentation?
No, it's not. Clearly, just straightforward. Don't make a medical diagnosis. And I think that's what I just said earlier, that if for any reason clinical judgment makes it necessary to know the medical diagnosis, can ask of patients input as to what the diagnosis is. But in most instances, don't need the specific medical diagnosis, the condition, physiotherapy, or management. What you need is the pathology, general pathology. I'll show you that from the physical diagnosis examples that we have. You don't make a medical diagnosis. So you don't do an assessment and you, as this is so movement impairment secondary to stroke. Say secondary to progressive conditions of the nervous system, non-progressive conditions of the nervous system, what have you. Something is showing the pathology, not the medical condition itself.
Okay, so we should just understand the pathology of that medical condition, but we shouldn't write it during documentation?
No. I will show you the examples of physical diagnosis. But as I've said, it all depends on your judgment. If you need the medical condition, what I'm saying is that it's not you that will make the diagnosis of the medical condition. You have to consult the neurologist or the physician or whoever it is that is going to give you the medical diagnosis. But for you,
apologies for the interruption, sir. I'm sorry to interrupt. Ms. Chidera said we should tell you that she has been logged out.
Ah, okay. So is there anyone that is joining both YouTube and so please let someone help us log into or maybe reach out to her if she's still on Ile. I think since they are listening, let someone send message to you, Edna. Ask someone that is on the what is it called? The Zoom. Sorry, the YouTube. Let them send maybe a screenshot. I think was it maybe Joshua Imoru, one that sent me while I was presenting earlier. I just don't want us to know
Okay,
them.
sir.
So if anyone can
Okay,
help
sir.
monitor and let us know what they are up to so that we'll carry them along. But
Okay,
I think I'm just going to continue the presentation before we get that.
Okay, so at this point, I can no longer see your screen. I don't know
No,
what
I'm going to share. You know, we are just answering questions.
Okay.
I'm going to share right
Okay.
now.
All right, sir.
Share right. Give me 10 seconds, you'll see it. Yes, so systems review.
Excuse me, sir. Good afternoon.
Yes.
I have a question.
Okay. Yes, go ahead.
Hello, sir. Please, can you hear me?
Yes, I can hear you. Go ahead. I can hear you. I can hear you. Is it your network? I can hear you very well.
Okay, sir. Okay, I can hear you now, sir. Thank you so much for a very wonderful presentation. New to our field, and it's going to take some time to implement, but we are still very grateful for it. So my question is this.
Sorry, can someone let me know if I'm the only one that can't hear her?
No, we can't hear her.
We can't hear her.
Okay, okay. I
Sir,
thought it was my network. So maybe
they
let her
have
type.
sent the questions from YouTube, sir, to
Okay,
me.
so let's take Aminu. Aminu will speak, and then you will now take questions from the YouTube. And if Chisimde is able to join us, she will speak. If not, please, you can type on the chat forum, then we'll read it out. Aminu, go ahead.
Okay, thank you, sir. I wanted to ask or give a contribution about the physical diagnosis. Most of us are just coming into, like, say, contact with all these terminologies of physical diagnosis. And those terms are supposed to be known first so that we can communicate between therapists. So I think there needs to be more sessions or more continuous educations on this physical diagnosis so that physiotherapists will find it easy to communicate between themselves in terms of this physical diagnosis, so that whenever we are managing our patients to have a coordinated term or a known term within the physiotherapy community, because most of us are used to the medical diagnosis. This is all new to us. So I think much needs to be done to make sure that physiotherapists know this, even from the training and continuous professional development among professionals. Thank you.
Thank you, Aminu. I assure you, next year, you see a lot of this. You know, because there is no awareness. I've been doing this, as I told you, from 2013. I've been doing workshops on this. I've taught in classes, both undergraduate and masters, and every workshop that I get opportunity to give a topic, I give this. But there has not been a national awareness until now that we thought of having this state by state and also having trained the trainers for people to learn it and also go back and step it down in the states. So for next year, we are going to have repetition of what we have done, because all these ones, we did them this year in the clinical pathway. Only that there was no awareness, many people did not join. I know a workshop that I had with only 2 people. There's another workshop that I had with only 7. There's another that I had with people that were like between 10 to 17. So because there was no awareness. But next year, maybe we'll reach out to more people, let them know how important it is, so that and also having this decentralized workshops. As I've said, any facilitator that has attended the trainers, and those that are going to attend this main workshop, please feel free after the training. If you have learned something that you can step down in your hospital, just gather 10 people and train them. That way, it will go around the country much faster than if it is always centralized. So thank you so much, Anita. That's a good suggestion. Yes, so Chidera, over to you. Or Edna is going to give us.
So since she already started, I don't mind.
Okay.
Let her continue, please.
Hello, sir.
I didn't start from Miss Dara.
Okay, so let me just continue. Maybe after my presentation, we can take more questions and comments. So
Hello,
let's
sir.
look at systems review. Okay, sorry, someone wants to speak?
Yes, sir.
Okay, go ahead.
Yes, sir. Sir, mine is just like a request, sir. Sir, please, sir, if we will be able to lay our hands on the documents so that at least after this we'll be able to go back, read through the documents and all that. I think it will be better, sir, if it is going to be shared among all the platforms.
You are not on the what's your platform for state, right? What's your
Yes,
state?
Sir, Borno State, sir.
We have a platform for Borno. You know, you have Brahma Jajire's phone number.
Okay, sir. I'll get it, sir. I'll get it.
Reach out to him. He's the facilitator and he has all the documents.
Okay, sir.
So if not, if you have my phone number, after this program, just send me a message. I will forward the documents to you.
Yes, sir. I have your number, sir. I'll do that as early as possible. Thank you, sir.
So either Brahma Jadra or myself will get the document. Okay.
Okay, sir. Thank you, sir.
Thank you so much. So let me just quickly check systems review. Our systems review is a course that we did in DPT for a semester. I think there were about 12 lectures and we still were not able to exhaust it. And therefore, it's not something that I'm even going to attempt to give to you this few minutes, 10 minutes, 5 minutes. What I'm going to do is just to show you what it means to have a red flag or a yellow flag to do systems review. So it's going to be very scanty, but as I've said, this year, I think just last Saturday, Dr. Zubair Usman facilitated a workshop on systems review. I don't know how many people joined, but people possibly did not know what systems review is all about, why they need to even learn it. Possibly have been having few join it. So, but this is something that's ongoing to see better. So I've already discussed this slide earlier. Reasons why we do medical screening, direct access. This is why we are having this workshop, so that you can to have first contact practice. Less you can medically screen, can be allowed to have first contact practice. Underlying diseases, it's important because if you don't do medical screening, focus on movement impairment treatment, and the patient will be allowed to continue to suffer from an underlying disease that has not been identified. Misdiagnosis and misdiagnosis. It's very common for medical doctors to send a referral, but the diagnosis is wrong. And that doesn't mean that they are not good. It just means that medical practice is complex, and sometimes all you need to do is just to do medical screening so that you can now write back to them to say that this is the diagnosis that came. During our assessment, we noticed that there is ABC, which is consistent with another system problem. Can you please look at it and review diagnosis? So you're not telling them you are wrong. You're not telling them that this is the correct diagnosis. No, you're not even mentioning what the diagnosis is. You're just telling them that the slides are not. Please, what slide are you looking at? Reasons for medical screening. Is that what you have?
No, sir.
No, sir.
We are on
No,
slide
slide.
1.
We are still on slide 1.
Okay, so let me stop sharing and share again. How about now?
Reasons for medical screening.
Sorry?
Reasons for medical screening, sir.
Aha, so that's the slide I'm on. So that is correct now. So I was talking about why we should medically screen, and the medical screening is a systems review. So direct access underlying diseases when the physician misdiagnose. So misdiagnosis is that there is a diagnosis they did not consider, missed it, and misdiagnosis is that they give a diagnosis, but it is not the correct diagnosis. So each and every one of these is possible, and when you medically screen, you are not better than them, medical diagnosis, but you are just like giving feedback that look, observe something. Can you please consider it? Then concealment due to fear or embarrassment. You know, physiotherapists are very close to patients because of the type of treatment that you give, that you are always together. Therefore, you become close. There are some things that patients may not tell their doctors or tell you. And therefore, if you are only considering your physical diagnosis and you are not medically screening, you will miss that too. And therefore, it's important to medically screen because of that. Early signs of disease. Sometimes patients don't feel the symptoms, but through medical screening, you can be able to suspect and you can be able to prevent those diseases from appearing in the future. Systemic diseases mimic neuromusculoskeletal diseases or injuries. I've given an example of low back pain that can be a referral from the genital system. You can have shoulder pain, especially shoulder pain. There are over 6 organs that can refer pain to the shoulder. Heart can refer pain to the shoulder, lungs, diaphragm. Even the kidney, when it is inflamed and it touches the diaphragm can refer pain to the shoulder. Your GIT can refer pain to the shoulder, biliary system, hepatic system, they all can refer to the shoulder. Therefore, if you don't medically screen, you're treating the shoulder when in actual sense the pain source is from the organs. You want to identify yellow or red flags, and also for primary healthcare. If you can't medically screen patients, how can you go to a primary healthcare center and have patients come to you and you are the only one in the center? Can't help them. We have to just allow a medical doctor or a nurse to come and assess them medically, screen them. So these are all reasons why we should do screen. I've already explained red flag and yellow flag. I'm not going to go into these definitions, but red flag, you have risk factors and symptoms and signs together. Remember, I said risk factors alone don't constitute a red flag. Therefore, if you do your biodata, past medical history, family social history, drug history, you sit to look at the risk factors and suspect a system, you don't refer at that point. You need to go into your history to see some symptoms. You need to go into your examination to see some signs before you now put everything together and say, I have a red flag. About yellow flag, only a few risk factors, you can have a yellow flag. What that means is that you don't have to refer, but you should further investigate to establish if there is need for referral. So now these are examples. As I've said, there are many slides. I can't go through all of them. I'm just going to pick a few to give you an example. Red flag for neurological disease. Now, you will say neurological is also a physiotherapy specialty because it is part of the human movement system. But the answer to that it's relevant to both physio and medical. So the neurological, that is movement related. So if you have injury and impulses are not going down and you have to give an intervention that facilitates the pathway for movement to begin to come, that is a physiotherapy approach. But then you can have an organic pathology affecting the neurological disease. When you have that organic pathology, identify it, you suspect it. If it is a red flag, you clarify. So what are examples of those things? And when you look at this, you'll see that it's evaluation, because you see things put together that helps you to suspect a red flag that you refer to a physician. Uncontrolled seizure for more than 5 minutes. So if you have epilepsy, you know the patient is on call. You don't have to refer the patient, because he will have a seizure for a minute or two, and then it's controlled, he's back to normal. For any seizure that lasts for more than 5 minutes, either in your history, the patient reports yesterday I had seizures, or maybe a relative said he had seizures and it lasted for 5 minutes, refer that patient to a neurologist or to a physician, because that is an indication of intracranial tumors, what is called status epilepticus. Any patient that loses consciousness, either in your presence, in the history they said before coming here, the patient lost consciousness, difficulty to arouse, that in normal circumstances, you touch the patient or you just pick the patient, works on. But now you have to beat the patient, you have to shake them, they are not arousing or they have lost consciousness. This is also a straightforward case. Extreme confusion that is not consistent with premorbid status. There are some people that are confusionists. Even when they don't have any pathology, they look confused. But if someone looks extremely confused and you ask about the morbid status before the condition, and they said, no, this person that is always alert, they are never confused, then that's a case. Signs of acute infection with associated neurological signs such as nuchal rigidity. So you have fever, the patient is feverish, the patient has all those signs of acute infection, and you find out that their neck is rigid, they have localized back pain. All this put together, when you see that for the patient, it is a red flag for an organic pathology. Signs of spinal column instability. So when you have decrease in motor or sensory status with change in position. So the patient is sitting, they lie down, the sensory or motor, so their weakness changes or their sensation changes when they change position. This is a spinal column instability sign. You can get this from the history whenever a patient reports that. So usually you can ask a follow-up question. When the patient says, I have a weakness, I have sensory abnormality, he said, okay, does it change with change in position? They'll say, yes. When I lie down or when I sit, I feel it's weaker or that abnormal sensation increases. This is a sign of spinal cord instability. I have rapid onset of focal neurological deficit. This indicative stroke is a case that you clear. So as I've said, I'm not going to go through the whole thing. These are other examples. But let's consider yellow flag. Progressive neurological signs in non-degenerative physical issue. So this is someone that has a non-degenerative neurological condition such as stroke. It's not supposed to be progressing. The weakness should not be getting worse, but it's now getting worse. So before you refer, you need to find out. Maybe the patient took a drug that is making the condition to be progressive for a short period. Maybe the patient is fatigued. But fatigued, feel more weak than you are not fatigued. So you need to ask those follow-up questions until you rule out any other reason for this case becoming progressive. Then you don't refer. So these are some of the examples. Another example down there that says involuntary movements or tremor. I keep giving this example with my father, may he rest in peace. He has this little involuntary movements in his hands. And towards, just before he died, a year or so, a few months before he died, to India, and he now complained to them. Please, can they check what it's because he was a veterinary doctor, so he knows about this diagnosis. He said, let them diagnose with Parkinson or signs of Parkinson. And they did their diagnosis and said it's not. So it's a normal thing. Some people can have those involuntary movements, but it's not. So you don't just refer someone because they have a tremor. But what you do is to do follow-up questions, because for it to be a medical condition, have a combination of symptoms, and unless you see that, you don't have to. You continue to monitor till you see a reason to refer. So these are just a few things that show difference between red flag, when you must refer immediately, and a yellow flag, when you continue to monitor until you see reasons for referral. As pulmonary, example, basis for referral, family history, personal history of pulmonary diseases. Can you see this risk factor? Then pulmonary symptoms of systemic nature. So these are now symptoms. You have fever, you have other symptoms of systemic nature. You have absence of findings indicating neuromuscular lesion, musculoskeletal lesion. Example, the patient reports shoulder pain, but when you touch the pain does not change. When you ask them to move the shoulder, it doesn't change. But they still have pain. And this patient has family and personal history of pulmonary disease. And they have pulmonary symptoms of systemic nature, maybe cough, and the cough is productive. When you see all those, even though the patient is presenting with shoulder pain, you say, no, this pain is referred from the pulmonary organ. And therefore, let me refer to the pulmonologist or a physician. So all these other ones that are there, anything you see during your assessment is a red flag. Sudden onset of dyspnea accompanied by weak or rapid pulse and decrease in blood pressure. That is one for evaluation. So the patient has sudden onset of dyspnea. Said, I have shortness of breath, difficulty breathing. And now you take the pulse. You see it's weak, rapid. You now take the BP and you see the blood pressure has come down. The evaluation for these findings is that there may be pneumothorax, especially after chest injury. So that's another question you'll ask. Have you had an accident? Maybe the patient had an accident, there was chest injury, but because it's not external, they don't even know they have had the injury. And therefore, putting together all this is a red flag. Just quickly refer so that they can get treatment for the thorax. So all these other ones are there, they are red flags, but yellow flag, look, age. From your biodata, the patient is over 40 years. There is history of smoking for many years. Past medical history of breast cancer, prostate, kidney cancer, pancreas, colon, or uterine cancer. Can you see all this are only risk factors? So you are taking biodata, say above, I'm 50 years old. History of smoking, I smoke. Past medical history, have you had any cancer? Oh yes, I had breast cancer, I had prostate, I had kidney, I had pancreas, colon, uterine cancer. This together is a yellow flag for disease. But is it enough to refer? No. You need to go into your history and get one or two symptoms of every disease, put them together, then it becomes a red flag. Recent history of upper respiratory infection. Anyone that has had respiratory infection, you should monitor them. So after your history, past medical history, in your symptoms, under history, if you have any symptom of respiratory problems, then you put together with this risk factor, and it can now become a red flag. That's when you need to. So in that slide, I've sent it out. You are going to see areas where if you have a pulmonary problem, it refers pain. This is refers pain to the shoulder, trapezius, front, to the sternum, back, between the scalp. So whenever a patient comes and got pain in any of these areas, always screen the system. So I don't think I'm going to through. So this is for cardiovascular. These are the things that you flags. These are the yellow flags. These are the areas that pain would have to. So if a patient comes to you and say, I have pain in my temporal joint, the jaw, the neck, chest, the shoulder, the trapezius, and also that the pain goes down the medial part of my arm, always think the heart. The heart can sense pain. These are other areas heart can back to. So as I've said, it's really, so I can see hepatic and biliary, GI symptoms, edema, ascites, dark urine, light-colored or clay-colored feces, right upper abdominal together are red flags for hepatic. So that might be a disease. So you yourself can ask these questions or assess what's there to ask your urine. Has it changed color? Yes, it's dark. Feces, what color is it? No, it's lighter. It used to be dark, now it's lighter. You are putting all that together, your evaluation is that they have hepatic disease. There is a lot, as I've said, this is short. Just understand that you need to review the systems because if you don't, can't practice as a first contact. That's just the truth. This is something that we'll look at. I know people have done DPT in some institutions. I know one of the institutions that didn't do systems review, and I told them, don't even come for licensing unless take those courses, because we can't license you when at the end of the day, go out there and say you have a DPT and you are practicing, but you can't do first contact because you don't know how to screen patients. So we'll not stop to license anyone, meaning upgrade the license from bachelor to doctor. Will not stop people from having the license, but to get the license, you must do all courses that empower you to serve as a first contact practitioner. So that's that with systems review. So let me ask if there are any questions before I go to the last part, which is to show the template after template. Any questions or comments? Yes, Suleiman Aminu.
Good afternoon, sir.
Afternoon.
Yeah, yes, thank you very much. So with respect to this systems review, from the little experience I had when I started applying this type of template for patients, so I just realized patients become too, they'll look as if I'm just wasting their time by asking them those questions, even though they came to me with their specific complaint, for example, knee pain. But for me going through to assess them thoroughly, they will look too concerned that it's as if I'm wasting their time. So what will be your advice, sir?
Now, it's about communication. If I come to you and you tell me that, look, I understand you have a chief complaint. This is what brought you to the hospital. However, let me tell you that there is this percentage, maybe you can even get a statistics, of people that come with this condition, but they have underlying diseases that we don't get to know until it becomes serious and it becomes life-threatening. And therefore, what I'm trying to do for you now is just to make sure that we check all underlying diseases and make sure that you have nothing to worry about before we begin to focus on the case that brought you to the hospital. I doubt if there's anyone reasonable that will resist such an offer.
Thank you
So
very
it's
much,
up
sir.
to you. You are not just a physiotherapist. You are a psychologist. You are a sociologist. You are someone that needs to empower people and justify why you do what you do. In as much as that justification, I don't think people will worry. Take long before it's on the table.
Thank you, sir.
Thank you. So Edna. Sorry, Edna, before you speak, let me just quickly, before you speak, let me just quickly get my code. I think I'm about to lose the charge, and the computer that has the charge is telling me I can't be allowed in. So please just give me 2 minutes.
Yeah, I want to talk from, I just do like this, time don't go, system make I don't give back. Tomorrow morning I will run. This good? Huh? You said this good? The popcorn. Okay. I be wondering this morning, I just.
Please, can we mute ourselves?
Oh, sorry, Miss Chidera. I wanted to find out. I was about to send you a message. Are you still with us? And someone sent more questions to the group on WhatsApp.
Okay, sorry, I'm back. I've just connected so that I will not lose the. Yes, thank you. So Edna, go ahead.
Okay, sir. Good evening, sir. It's about the questions from YouTube, sir.
Yes.
Yes, I wanted to find out whether Miss Dara is with us, but it's like she's not here any longer.
Okay.
Are we taking the questions now or till the final
No, if
presentation?
you can check them, go ahead. Go ahead, check them.
Okay, sir. So, sorry. I think the first question here is about okay, I'm sorry. Yes, this someone said, should we still use this format when we are not the first contact with that patient?
Okay.
Should we still use this format?
Yes, that's fine. You know, there are some things that you do, you don't lose anything. Even if it's not first contact. Right now, there are many people that have the bachelor because the curriculum has been upgraded from the BSc. Therefore, you are having some level of content that helps you to be able to do screening. And when you do the screening, even if someone is coming from a medical doctor as referral, so it's not first contact. I remember under the justification or the reasons for medical screening, he said missed or misdiagnosis. So you are not first contact. It's sent to you, and you are expected to only treat within the scope of your practice. But if you do the medical screening, or you don't assume that it's only the chief complaint that they have, and you are able to now suspect other systems of the body, will it be harmful if you suspect and you refer back? So even if you don't refer back, at least you can advise the patient. Say, from what I'm seeing, there are signs or suspicion that you may have something. Can you please go and see the physician? Don't even tell them that. Just go and say, feel ABC. Want them to check status. So we are transitioning. But even from before you do your DPT and we completely transition to first contact, I don't see any harm. Template, because the template will help us, even if we are not first contact, at least to be able to know what has been sent to us, whether there is any feedback that we give that sent case to us. So I hope that makes sense.
Okay, sir. So another question, but I think from your explanation, you've already answered the question, but let me still read it out. How can you get risk factors of a condition when you're yet to diagnose the condition?
You don't need diagnosis to see risk factors. It's the risk factors that will lead you to a diagnosis. It's not diagnosis that leads you to risk factors. What is risk factor? A risk factor is something that indicates you are at risk of having a condition. So what do you see first? Is it the condition or the risk? Sometimes you will have the risk factor, but you don't even have the condition. It doesn't exist. Why you are checking the risk factor is for prevention purposes. So that you now tell the patient that, look, this alcohol you are taking is a risk of having cardiovascular disease. You are going to have, stop using it too. This smoking, that is going to give you pulmonary disease. Stop. So, but sometimes all those risk factors put together and some symptoms, they show that signs, the symptoms are already there, but it starts from the risk factor and then it now gets to the symptom. So if you have the risk factors and the symptoms and the signs, what is a diagnostic criteria? A diagnostic criteria is when these clinical features come together and they form a criteria. That is when you say the disease is there. So it's very important to get them before you even get to the point of diagnosis. Either you prevent the diagnosis from even coming in, or maybe if it's there, you'll identify it through assessing these factors, the symptoms, and the signs. Yes, Edna, over to you.
Oh, yes, sir. The next question is, will this new process be taught in universities? If they are taught the old SOPIA method and all, won't it be a shock to them when they start internship? But I think this question,
This has been
was
answered.
addressed earlier.
It was asked. I answered it. I said, even this workshop, that is the purpose. So that all states, both clinicians, academicians, people that work in universities and teaching hospitals, they will learn this. And if we agree, we'll then change the practice on our own. But if we don't change it on our own, I've given the consequences. In the board, we can decide if you complete your degree before you go for internship, don't know how to use the new method, must go and learn it before issue license to you. So it's a very simple matter. In the beginning, it's going to be a free will. Let people select it their own. But at the end, if we decide this is what we want to do, then we'll now make it a rule that you can proceed to internship once you learn it.
Okay, sir. So the next question says, please, should the hospital facility also have the movement room? How much will that cost?
I think I've also answered that. I said we are going to come up with the list. I think I gave many examples when, who was it? Maybe Dr. Olani or someone asked. I gave examples with the movement. That was when I was mentioning the name of Dr. Dayo. I said there are many of such things. I gave example, motion analysis standard. And then remember in the presentation, I gave some that are even free. CABA and the functional movement analysis and all that. We are going to put the list together and we'll send it to all hospitals that they would know they need to put in.
Okay, sir. There are more questions here. So how do we react to obvious misdiagnosis?
Yes, so
what is the best way to communicate misdiagnosis back to the referring team without appearing rude?
Yes. So what you do, you are not going to give an alternate diagnosis. So you are going to say that, thank you so much for referring this case to me, a case of so condition, because in the referral would have said this is the diagnosis. You say, while assessing the patient, I noted that the patient has pain during urination and color is so color, either blood in the urine or it is dark or it is on the stool is so, and this seem to be symptoms that are related to a hepatic system, nervous system. Please, can you further review this, the case of this patient? With that, you are not telling them that they were wrong. You are just saying that this is my observation. And this observation seems to relate to a particular system. And you are not even telling them that they have missed that system. You are just saying that these symptoms relate to this system. Can you please review? Tell me who is going to come and query you that you have disrespected them. If they truly missed it and they realize that they have missed it, are they going to come and fight? Because if the case goes up, the first question will be, why did you miss it? And if they are going to do investigation, they are going to make those assessments. So ask the patient, is it true that the color of your urine is this color? You say yes. Then they will now ask the medical doctor, did you ask about this? You say no. So is he the one that's going to begin to fight? So if you have concrete evidence that indicates there is a diagnosis that has been missed, just write it. Don't say what the diagnosis is. Don't say that they didn't do something. Just state that this is what I've found and it seems to be related to this. Can you please review? These three things are the key issues that you put in there. I've done an assessment, I've found this. It seems to be related to this. Please, can you further review? Chicken. So over to you.
Oh, yes, sir. The next question there is, do we have practicing physiatrists in the country? I perceive overlap of roles of physiatrists and GPTs, physios.
Now, see, organic pathology, let me give you an example. Someone has Parkinson's disease, have DDT, other condition, and you want to treat them. Need them to be on levodopa, if it is Parkinson's disease, for example, on. You know that it's on and off levodopa. Take levodopa, in particular hours, they will be on the drug, meaning the effect of the drug. Therefore, you have to do movements, but when they are off the drug, rigid. So a physiatrist is someone that understands these concepts of rehabilitation. What they treat is organic pathology. They are not doing movement impairment. Their treatment is not movement impairment. That is because we really don't see the difference between distinction, scope of practice, organic pathology, and physiatrist is looking at rehabilitation from the perspective of organic pathology. But his understanding of rehabilitation makes it in such a way that he knows what you need and he can give you what you need to do your physical treatment. The same thing with you. Understand what he needs. Therefore, when you are referring to him, you know how to relate. So it's not that they do what we do. It's just that we are under the umbrella. It's just like a nurse. It's a rehabilitation nurse going to come and do passive movement and give exercises to patients. They don't. But they understand their work from the perspective of rehabilitation. It's like occupational therapy coming to do physiotherapy, or speech therapy coming to do physiotherapy. Everyone has their scope of practice, but we all understand the patient case perspective. That is my understanding. It's possible there are some countries that have brought in physio into it, maybe because of tax shifting and tax sharing. There is no one that will do it, or maybe there are people that will do it, but they are not enough. They will now say, let someone take over. For example, in the UK, all know that physiotherapists prescribe drugs. Some categories of medical doctors, no, just because of tax shifting and sharing. So this is my understanding of physiatry, something happening that I don't understand. This is what I think stand about physiatry. So Edna, maybe we stop with the questions.
Sir.
Let's take peace for day with me. After that, I will complete the presentation and then we can have more questions come in. Yes, peace.
Okay. Good afternoon, sir. Thank you so much for the presentation. So I wanted to say that there are some cases where patients build so much trust in, like when somebody was asking then that when you're asking these unnecessary questions, they tend to dismiss you and everything. So there are some cases that is the opposite. So when you ask them these questions and they feel so seen and understood, because like you said, they spend more times with us than they do with their physicians. So there are some cases that they are so confident, they trust you so much, then they start to ask questions that are outside of your scope. So in these cases, like they start to ask so many questions that are outside of your scopes, like whether you know the questions or not. I don't think we should be telling them things that are not within our scope sometimes. So in these cases, how do we tell them that, okay, this is outside of my scope without, number one, being dismissive, and then in such a way that that trust and confidence that they build in us, they don't lose it because they feel like, oh, you're supposed to know. And sometimes even if you don't know, or even if you know, you're not supposed to tell them. So how do we respond to that without being dismissive to the patient as well?
Okay, I understand where you're coming from. This thing happens to me few days, weeks ago. Maybe some of you would have watched this Good Morning Nigeria NTA. There are questions about issues of, it was about stroke, and trying to ask questions about what is it called? The risk factors and ways of prevention and all that. And I was focusing more on what is within my scope of practice, how exercises and other things can help prevention of stroke, blood pressure, and what have you. I was asking, so when the questions now come directly about nutrition, I stated what is theoretical, but I said the actual practice should be a nutritionist that will direct that discussion. I said, because that's what they have studied, this is what they practice. I can understand it from theoretical and academic perspective, and I will mention some. But if you want a practical answer, you need to consult. So even if I know it very well, I will still say that the practical and part of it that should be explained, or people should be guided by the nutritionist. If there is something that has to do with drug, I will say the theoretical or academic part of it, but I say the practice of it will be best explained by a medical doctor. If there is something about how to test cholesterol, for example, I will give the theoretical background that this test, this is what they do. But how is the test done? Other implications that are outside of theoretical aspects, there are practical components, I will refer. So don't hesitate to say, I don't know. don't hesitate to say that this is the person that is responsible, because that way you will even educate the patient to understand that this is not within the scope of your practice. Let them not expect a practical solution in that particular perspective. Who am I? Is that I'm a movement specialist. I look at the human movement system. If I need someone to handle nutrition, I will call the nutritionist. If I need someone to handle drugs or surgery, I will call the medical doctor. Let them know you for you are, and you'll be able to let them know theoretically, this is my understanding, but practically, practice-wise, this is the person you should consult. I hope this helps.
Yeah, thank you, sir.
Okay, so let me just quickly complete the presentation, and then after that, we have questions and answers. So we are going to look at the APTA template. I don't think we have time for me to also open the one that we adapted. So let me just present this at a later time to send. So this is the documentation template for physical therapist, patient/client management. I hope we can see the template. Yes, so I think it's only name that is just for record purpose. Any other thing in this template? Remember, during the discussion on clinical reasoning, talked about narrative reasoning and diagnostic reasoning. Every single question here, we are going to use it to think about a diagnosis, think about treatment, how to give rehabilitation to the patient. Remember when we talked about street address, talked about the issues of toxins and issues of emittance from factories and biofuels and what. So the address of the patient should help you with diagnostic reasoning, because it will serve as a risk factor for some diseases like urinary that we saw. Systems I showed you on the slides, I had address of the patient indicative risk factor, some system. So that's important. That thing I would turn for narrative reasoning is where you live, determine what sort of rehabilitation should be planned for you. It's not just about your house. The street you live, what type of street is it? Is there a lot of traffic there? Just free that you street and do exercises, or at least move around to the neighbor, and there is a lot of traffic. Then the training will have to how to navigate crowded environment. So that is for narrative reasoning. Issue of your age, we all know, higher age, neurological, muscular, other age, musculoskeletal. Gender, males, musculoskeletal, females, cardiovascular. Type of insurance, we remove it. Race, we all know, is a risk factor. So, say African American, having stroke, things like that. Ethnicity, language, education, higher education, what the risk of having infectious diseases, social history. Sometimes it's important. Narrative reasoning. Find out from the patient if they have any customs or just beliefs, issues that might affect care. I think there are many customs and that you need to consider. With whom do you live? This is for narrative reasoning. Just want to know the support system of the patient. And use that as evaluation for diagnosis. Referred you, sometimes this helps for you to suggest what problem the patient has. He said it had me suspecting the urinary system. Employment, job, school pay can be for diagnostic reasoning. Someone that says I'm a driver, how long drive per day, any other. It's not risk of having musculoskeletal, but it can also serve as a narrative review, thinking the type of job, so that you need to check the person to be to job. The living environment. Living environment. Does your home have stairs, ramps, elevators, uneven terrain? This is for narrative reasoning. And use it for diagnosis. No. Obstacles and the type of house and their rehabilitation better. Where do you live? Private home, private apartment, rented room. Knowing this usually will social status or social state of a patient. Possible that it is a rented apartment. Next 1 or 2 months, they may have to leave. You must see them for the next 2 or 3 months. You need to prepare them. They need to do. Avoid prolonged. Stop from coming to the clinic. Something like that. So this is for narrative reasoning. Their general health status, social, they need to know. You need to know, what do they think of status? Might be a social thing, a psychological thing, that you can be able to some guidance or send them to someone that is going to give them some social or psychological support. Social, so that's the social history. Smoking, not just whether they smoke, how many sticks or packs per day, same thing with alcohol. Then the exercise, describe the exercise, on average, how many days per week, or how many minutes on. So you are now coming up with something that's more comprehensive. Evaluation. Not just asking whether you have said yes and say you are no. Then the family history. Can list some of those family histories, and then you now have an open-ended question. Any other, apart from the ones that are listed. Then medical/surgical history. Now ask them the histories, whether it is fractures or the circulation. Then always have others. There are males. If there are males, ask them about prostate. Females, PIDs, pregnancy, other things. So can you see that the APTA template go through about 22 different sets of questions? So you now ask the patient, what is your chief? Here's the APTA template. You must have done a lot of evaluation. Are you able to say coronary system is suspected, hepatic system is suspected, cardiovascular system is suspected? I'll ask the chief. Then it will now be neurological or orthopedic. Then you now go to your history, where you are going to now deal in categories of conditions under the systems suspected. Medication history, functional status or activity level. That's what you are going to ask for you. Basis of rehabilitation. Systems review. After you have done your history, you now want to pick each of the systems. Whether the first part has suspected the system or not, must ask questions of each and every system. And the slides on system review will guide you. We're talking respiratory, blood pressure, heart rate. I know we mentioned that. So when you ask these questions, I'll use the evaluation in those slides. Say, oh, I suspect a red flag, yellow flag, this system, that system. Please, someone, Suleiman Muhammad Bashir, please, can you mute yourself? Maybe if anyone that is, So this is the systems review. And after you have done that, now go to your examination. All those tests. Now, Suleiman Amin was the one asking about Kaaba. He said, where does it fit in all this? When you get to this documentation, test and the measures, do that. And so this is not really the only ones that you do. In fact, you might not do some of them because what you suspect in the earlier stage will determine what you are going to assess. You take your notes, then you now make your physical diagnosis. So for those that have been asking about physical diagnosis, these are examples. So for musculoskeletal patterns, primary prevention risk reduction for skeletal demineralization, impaired posture, maybe the only thing that you have found in all your assessment is posture. Impaired muscle performance is possible. You see patients that is just muscle performance power. Any other thing is not. Impaired joint mobility. Remember those terminologies that we are talking about. Motor function, muscle performance, range of motion. Now, associated with connective tissue dysfunction. I'm not talking of osteoarthritis. I'm not talking of any medical diagnosis. Connective tissue dysfunction. Impaired joint mobility, motor function, muscle performance, range of motion associated with localized inflammation. It doesn't say what type of infection. Is it a bacterial infection? What type of infection? No. It is associated with a localized infection. You see another one associated with spinal disorders. It doesn't say what exact condition. If you go down to muscular, it's similar. Impaired motor function and sensory integrity associated with non-progressive disorders, central nervous system. Either for acquired in adults and infancy, this one is for adulthood. Similar. Non-progressive disorders of the central nervous system in adult. Impaired motor function and sensory integrity associated with progressive disorders of the central nervous system, associated with peripheral nerve injury. So the same thing will be to cardiovascular. Impaired ventilation, respiration or gas exchange, and aerobic capacity and associated with airway clearance dysfunction. Doesn't say asthma, bronchitis, what have you. In as much as the condition is an airway clearance dysfunction, that is the pathology. Then what comes before that associated are the movement-related issues to deal with that. So can you see integumentary? So that's integumentary. There is another document that I will share at a later time that has more details about all this physical diagnosis. In fact, I have a textbook, big, very big one, about practice patterns that has not just the physical diagnosis, but what do you see in your assessment to say this is the physical diagnosis? It's big, and I'm going to, I don't have the soft copy, but I'm going to send you a link to how to buy textbook. Then for systems review, I'm going to send you a textbook. That one I have the soft copy. I will post on the so that your coordinators will share on various textbooks. That book is very comprehensive medical script systems are ready. So after you have gotten your diagnosis, very important to enter what your diagnosis is. Expect the patient to get recovery each of symptoms. Have your stated goals as a plan of care. Expected outcomes. Then you choose the interventions that you are going to give with dosage. Each must have dosage. If you need to educate the patient, you need to list those educational information to give. Must have a discharge plan. Must say when you are discharged, when you discharge, what you are going to do to them, give them possibly ask them to come 2 months or 3 months or 2 weeks. Must have discharge. This is the end of the template. As I've said, we are adapting it and now we have a name, move what we don't need, add what we, then we'll distribute it to all institutions, facilities, so that it will now become a Nigerian template to use. But this will be the general template. Get to that test and measures. Then every specialty will have another template that will now have what assessments they do in that specialty. So neuro having things like, say, Oxford Grading System, results the chart. Then maybe back balance scale, then sensory assessment, say this is the assessment, this is the score, this is the information about the response of the patient. And we'll have 2 templates. One, the general template, the second one for assessment that would have space where you will enter the score. And as I've said, unlike a journalist, don't need to commit things to memory to ask the patient. And keep the tempo. Ask the patient, ask the patient, enter the evaluation out your physical. Sorry, I've spoken too long. Said I was going to time, distance, and access, but I was not able. Let's see if we have discussions. So I've talked too much. I've hand over to you. Comments and questions. Thank you so much, everybody. Yes. Ochai can unmute and speak.
Good evening, sir.
Yes, good
Sorry,
evening.
I had a network glitch when you were responding to the question about having a movement lab in the hospitals and what does it require. Because some of these things, it won't be nice that somebody train in a university and graduate and then comes to work and those things are not there. The knowledge that he or she has acquired will not be well appreciated, and it will not be the person will not use that knowledge in real practice when the person is working. So I was asking, is it possible for the hospitals to have this lab, and what does it cost, and how do you go about it? Because for those that are in the management board, they need to facilitate and push it through so that they can have these things in their own hospitals too, in the department, and then it should be used. So I said I should ask. And some of these things about the second observation, sir, about this physical diagnosis, is that some of us were actually taught. It's not like we were not using them before, just that the majority of us were actually given the medical diagnosis. But there are some that actually have this idea, but because so many of us are using the medical diagnosis, then we tend to move towards that pattern. But actually, we are aware of all those hypermobility, limited range of motion, that these are the things that we treat, and these are the things that should be our diagnosis, that should be our impression, not the medical. Some of us actually are aware. So I am really happy for this presentation. I'm happy with this exposition, so that we'll be able to have this idea and practice effectively wherever we work. Thank you, sir. We truly appreciate it.
Thank you so much. So the first question, I think I've addressed it, just like you said, maybe the network. There are two issues to it. Number one, 26, we are going to do a lot of training about how to use them, how to do them. People that have some of expertise that we need to help us with the trainings. Then now switch to regulation. Our guidelines for accreditation will change. Those that are not costly, we'll put them as general things that every hospital have. If you don't have them, no accreditation for you. But others that are costly, expensive, will now place hospitals levels. Have more sophisticated ones will be higher level. If not, you will still get your full accreditation at a lower level, and people from outside will know what you have so that they will and services. Then first 2 years will just be doing advocacy and training, but after 2 or 3 years we'll now begin these new guidelines for patients. Then the second one that you have mentioned, that's why we are doing this. We want training to change right from school, so that learn something. So training changes, but also the clinical practice changes. I think there are more patients than academicians. Even when we train the trainers, almost everyone came from either HODs, or chief, and they embraced it and assured us that when they go back, to change the practice in various hospitals, so that you don't just learn it theoretically and you go to the hospital, you go back to medical practices. So I believe the commitment we had trainers, and also the one that we are having now, I believe the practice will change locally in each facility. And as I've said, please influence others that have not joined this hospital where you are the only one that has attended. Please put them together and say, going to give some hours of shows on this so that you end them. So that's how Chinu. Thank you so much, Suleiman Amin.
Thank you very much, sir. Am I audible, sir?
Yes, you are. Go ahead.
Sorry, please, I beg your pardon, sir. Towards the last part of the explanation of the template,
yes,
your voice was breaking. Please, I don't know if you can come again concerning, I guess you were trying to explain that one can print the form.
Oh, yes. What I was saying is that you don't have to commit the whole of this template to memory. And you now go and be doing it and you missing things. I mean, in the first instance, you can begin to use it to collect data. But as you do it over time, the non-analytical process sits very well. Then you don't need it, maybe. You can just ask the questions and then you record on your treatment sheet or your prescription sheet, and then later you make your decisions. So I'm just saying, don't try to look smart. And then at the end of the day, don't ask the right questions. Don't have the right questions asked. Don't do the right things. You are not going to have it.
Green cup. That's not green. Green cup.
Yes.
Good.
So Moses, MD. MD, you need to unmute. But Chai, can you please mute yourself?
Sorry, sir.
MD Mumwe.
Sir, yes, sir. Can I?
Yes, go ahead. Go ahead. You have muted yourself again. Okay, Rukaya, before MD sorts his speaker out, please, Rukaya, go ahead.
Okay, sir. Thank you very much, sir. Actually, mine is just like a contribution or a suggestion. Is it possible for the MRTB board to create a software system whereby all these templates and everything is fit into it, and let's say every clinic in Nigeria gets this software and uses it in their system, since we are all adopting electronic record now? Did you get me, sir?
Yeah, I don't know. That's okay. Okay, go ahead. I think I had you. Are you done?
Yes, sir. Thank you, sir. That's
okay.
the question.
Yes, okay. I think it's EMS, Electronic Management System. Most hospitals have EMS. In fact, the Federal Ministry of Health has mandated all agencies under its here to digitalize. I think it's a head of service directive, not even Ministry of Health. So many are doing that. Now, but the issue is, it's not where that is the issue. Because many hospitals are launching the software. What the issue is, knowing what template to use in the software. So what we are going to do as MRTB, we are not going to come up with the software because we don't have the mandate to create software for hospitals. What we are going to do is to come up with the template, information that should be uploaded into the software, and then we'll now write to facilities and give them the template so that when they are developing their software, they should consider this particular template that we have agreed to use. So that is what we are going to do. Thank you.
Okay,
MD, are you still there?
Yes, sir. Thank you.
MD, if you are not there, Mariam Musa, go ahead.
Okay, thank you very much, sir, for this presentation. My own is just like a case, it's a suggestion about template, because most of the hospitals that have started adopting all these records, and sometimes there were, like in our hospital, there was a time they asked us to submit a template, and we have various units. The assessment for various units is different, so we are now suggesting limiting that whether a specific template must be adapted for each and every specialty, so that we can be using it So because now our record, the way we used to assess patients and document is that is not a standard documentation. So thank you, sir.
Thank you very much. So we are going to continue to work on this, the central template and also the specialized templates, so that when we complete the process, we'll call for the stakeholders meeting, do a validation, and then we'll now package it and send it to all hospitals and now use it. Thank you so much, Joseph. Maybe MD, let me go back to you. MD, that's still there.
Okay. Thank you so much, sir. I don't know if I'm audible now.
Yes, we can hear you now.
Okay, thank you, sir. Although one of the last speaker touched part of the questions I want to ask. Thank you so much, Honorable Registrar, for bringing this to our notice. I think now it is going to be much better for physiotherapists to adopt a unified something, because I've been to quite a number of facilities, and when I see physiotherapy doing their diagnosis, I now see a lot of discrepancies. I begin to wonder, like, what really do we want? Which way is the way forward? But now with the advent of this unified method of assessing patient, I think it's going to be much better in the future. And just like the other person asked, this issue of EMR, I just want to reiterate, it needs to be put into consideration, because they are limiting I think there's a limitation to the scope of physiotherapy in that EMR. They just give you 2 lines to put. You can't capture what you need to do for a patient within just 2 lines, and they expect it to be done.
Okay. Thank you.
So
Thank you. Okay, you are still speaking. Okay, go ahead. Go ahead. I thought maybe you finished. I think maybe it was network.
Yes, sir. Yes, sir. So this is the concern I want to raise.
Okay. So that's fine. Thank you so much. I think I assure you, I'm going to continue with the process until we get to the point that implementation is done. Joseph.
All right, sir. Thank you for this wonderful presentation. It's a presentation that I've always looked forward to, and I was so happy when I saw it. And thank you, sir. It's like they say knowledge is continuous. I remember there was a time you took a presentation like this, and it was wonderful. Like in my center, we have transit to the use of software. We don't document using paper and folders. We use our own software that we use. And our observation that we saw in that pattern was that it's more inclined to medical pattern of assessment. So I'm so happy that two of the participants that asked a question as regards to that effect. I'm happy for the response you gave anyway. I want to thank you for that. So I don't know how soon it will be for us to have our own PCO kind of template that will be spread across the whole institution, so that our documentation will be a kind of uniform one, sir. I don't know how soon it will take effect, sir.
In the first quarter of 2026, I assure you of that, because we have the adapted template ready. Only thing is that beginning to get even familiar with the issue of stakeholder engagement, and I wouldn't want to just write from the board to the CMDs before have more engagement with stakeholders. Let people understand what it is, let them agree, so that when it gets to CMDs and they scale it down to their departments, everyone would be implementing what they owned, even to them. But if not because of that, we have sent it few days or weeks, but we are going to take our time, wait until after the holidays, have the stakeholders meeting, and then go ahead and write to. So before we check, yes, thank you. Before we check more comments, let's check some of the comments on the chat forum. Is there any difference between the after inpatient? Actually, I did not inpatient and outpatient. There are 2 after. What I've shown you now is the outpatient. So I'm going. when we are doing our Nigerian template, we are also going to consider that to have two separate. Have one has section in patients with but I have two for that's about discharge patient, unit management, whether inpatient or outpatient. It's inpatient, the discharge plan will have plan for patient after discharge. It's outpatient, can continue to treat the patient for to have a discharge plan when patient is going to stop coming. Maybe when see that the patient has reached a particular stage, say instead of coming to go, you'll be coming once in a month or once in 2 months. Must have a discharge plan. Patient. Say forms like they are say as I've said patient and outpatient. After template is comprehensive and saves time. So I use that sincerely, no matter whether you're isn't this overwhelming time clinics or hospitals? See, please, let's not be talking about wow. We are talking of one petition being named. This will take 2 hours. The reason why it will take long is I went to see, we even mentioned the name, it's a neurologist. I took a patient to see to Owola, and what will take us 30 minutes to do, looking at the assessment of proprioception, tactile sensation, Oxford grading system. If it don't take you 30 minutes, he did it within 5 to 10 minutes. It like this, he has finished. He says, okay, can you close in? Okay, close out. Can you push up? Can you push down? What do you feel? What do you feel? What do you feel? What do you... Before you know it, he has finished. If you do it regularly, it becomes part of you. It will not take that long. But the reason why I'm not happy that we are talking about the number of patients, we are the ones causing problems for ourselves. A neurologist will go to a specialty clinic and tell the nurses, I will only take 5 patients or 10 patients maximum. And he's not doing physiotherapy, he's just sitting asking questions and prescribing. And anyone that comes, you say, I've filled it. Even in the United States, go and see how people in Nigeria, because you will get appointment closer. There they will say, we have patients in the next 6 months, we can't see you. Because they want to treat the ones that they are taking properly. But in Nigeria, physiotherapists will want to see 50 patients in a day. None of them will get better. And if you talk, they will say, our CMD said we must see because we are not making money. Tell them, what is it called? The clinical practice guideline says I must take 1 hour to see this patient. And I can't kill myself to see 10 patients because physiotherapy is a physical thing. I can see 5. If you want us to see 50 or 100 patients, employ more physiotherapists. And if you want to make more money, instead of charging 1,000 or 2,000, charge more. A surgeon will charge 300. Now maybe they are charging 1 million for surgery. And a patient that is not rich still go to someone and maybe a politician and say, I need money to come and do this thing. You don't properly. You don't want to ask people to pay 1,000 and you just give them infrared and they never get better. What's the point? Making it very cheap and they don't get anything out of that process. So please, let's talk to ourselves. If we need to do this thing to be able to get a good diagnosis and have a treatment that will help the patient, let's do it. Let's communicate this to our hospital management. Let them understand, just like the urologist or neurologist see only 5 or 10 patients in a day. We also should not be different because we are also professionals. We want to give the best to patients. I'm sorry that I'm becoming emotional on this particular question. Daniel, it's not about you as a person, because it's about us in the practice. We want to please our management, we'll see 50 patients, make money for them. But at the end, not a single patient is page. Okay, so that's private clinics are already just after patient. That's good. Too much, but then can't expect get that reputation that we are asking for when the work is light. That you just do half page of clicking, do search and infrared to the patient, and you expect have to upgrade, have to change the way image is through. Thank you so much. I don't know if there's any and there is none asking from the tube to give us thoughts and yes. Okay, is someone trying to speak? Quila, Chibo, please can you mute yourself? So what of those facilities which are already SPO in each of the units? I have mentioned this. So we'll have one general one that everyone can use. When we get to the point where we have different outcome measures to use, then have a template for each of the specialties so that each specialty will have the general one, and then they will now attach a specific one going to use unit or specialty. Yes, so Chidera, are you there? I know it's already late, 4:30, so in the next 4 minutes.
Yeah, I'm here, sir.
Okay, any general question from the other section?
None, sir. I think Dr. Edna must have taken all.
Okay, that's fine. So let's just close. I don't know if you have any information that you want to give with regards to process, at least that we are.
Okay, sir. Maybe I think here is even a good place to
Coordinate.
really explain. Yes, sir, to explain everything.
Let me apologize to people if there are any challenges. Go ahead, Chidera.
Yes, sir. Okay, so first off, I would like to apologize for, the many times people had to reach out asking for links and all of that. There were just some hitches we had along the line, but then the aim is to serve us better. So we are hoping that for the hands-on and the remaining of the training will be more, less stressful. Will be less stressful for every one of us. Then the structure that we are having here is that aside the LOC from the national body, we have facilitators and state coordinators for each state. So I will encourage us, if you have any complaints or anything, you can direct that to the state coordinator. And I want you to believe that it will be handled properly, and hopefully the list of participants will be published. But then if you think that maybe you registered and your name is not on the list, there could be one or two reasons. Either that you didn't send in all the details, which made me not to impute all the details, or you didn't respond to the follow-up emails. So that will be all. The rest of the things will be sent to the group chat. So please, let's maximize the use of our group chat and then our state coordinators. That's all. Thank you, Registrar. Thank you, everyone.
So thanks, everyone. Have a nice day. See you all.
Thank you, Prof. Baldo.
Thank you, Prof.
Thank you, Prof.
Thank you, Prof. Thank you, sir. We are very grateful.
Thank you, Sam.
Please, is the meeting over? My network kept logging me in and out.
Yes, yeah, carry
It's over.
Okay, thank you. Thank
All right,
you.
take care. Bye.
Bye-bye.
Okay, host, at the host, not, please, we'll be waiting for the record.